Kazadi.
Unmute yourself, Imad.
Hey.
Unmute.
Imad, you are muted.
I'm trying. Okay. Do you hear me now?
Yes.
Yes.
You guys, oh, wonderful.
Hello, Ayman.
Hi,
Hey, Matt.
Victor. Hey, how are you? Everybody who is missing?
Well,
Yeah, because I received a message from Eka from Indonesia, but somebody is there fixing. Yeah, he
No,
wants.
it's fixed. It's
Hi,
fixed.
Imad.
And John, I just opened the YouTube.
Okay, let me check the page. It should be on the page. I'll be able to see it.
I
Wonderful.
saw.
I
can you lock this door? Oh, we should have asked him. Yeah?
Where is Hype? I don't see him.
He's
to
there.
the right.
He's in Biratnagar.
You have to rest here.
Hi, hello everyone.
Hello.
Hi, Ka.
Ah,
Sure. Hello, how are you? Yeah, very nice to see you all.
But you know, Matt,
So today I'm the translator. Okay, I'm in Beijing. And,
The
we have
next
a
course
group.
you will be on, inshallah, I hope. Yeah.
Matt,
I think there's a name.
76.
Yeah.
Hi, Ramesh.
Igor,
Hi.
Igor just joined. Igor just came from the surgery.
Oh, okay.
So many.
Hi.
I think if we are here from the start, we're disconnected.
hey, Aip,
Great to see you.
Aip.
Roy, what is this?
Hey, we're waiting for you since yesterday, man.
Yeah.
So, Roy, it seems
Yeah.
like and the show starts.
Yeah, your sound is getting cut off, Aip.
Yeah, I think I sound is getting.
Okay, now
Yeah, it's better.
I have this big mic just for this meeting.
So big, so huge.
You're wearing some bathrobe, Aip.
Yeah, I was about to say that.
Take it off to see my bulging muscle.
Okay.
Hey,
Hey, Igor.
good to see you, man.
Cut off.
Yeah, I think I sound is getting.
Okay, now
Yeah, better.
Hey, I
I have this big mic just for this meeting.
So big, so huge.
You're wearing some bathrobe, Aip.
You are
All the people will be seen like this.
okay. That's why, because I think that if
hey, you are also live on Neurosurgical TV.
Only the panelists will be there.
okay.
The people who are speaking.
Yeah.
Yeah, I think
Happy to, yeah. Maybe a rubber from.
Yeah. Who knows? Probably. Okay.
So big, so huge.
So what is this shit for?
Project. That's what it's projecting there.
Yeah, but why is it red?
And because we need to work.
Also live on Neurosurgical TV.
Just check.
Kazadi, it's
No,
nice.
because
Kazadi,
we would-
you have your
Yes.
patient behind yourself.
Sorry.
There is a patient behind yourself.
Yes. You see.
He's doing well. Obviously, in very good condition.
He's doing very well.
Yeah, still
He's doing very well.
Still standing up.
That's the time when I was learning the skull base surgery.
It seems we have the same zest as we are meeting together physically somewhere.
Yes, definitely.
Good sign.
No, the Akura Matata team is
Yeah, we are missing each other.
We started.
Doing well. Obviously, in very good condition.
He's doing very well.
Yeah, still
He's doing
standing
very well.
Still standing up.
Yeah, they can't, they can't give us chips. Yeah.
No, everything is cancelled. We were supposed to be in Brazil.
Yeah. But Zanzibar also, there wasn't right.
Everything is
It
gone.
seems we have the
we
same
have-
zest as we
You're
are
happy, right?
together physically somewhere.
Yes, definitely.
Good sign.
No, the Akura Matata team is
Yeah, we are missing each other.
Look at this.
Kazadi, Hakuna Matata.
Obviously, in very good condition.
He's doing very well.
Yeah, still
He's
standing
doing very well.
They can't, they can't give us chips.
We were supposed to be in Brazil.
But Transpetrous, the question.
Since we have the same, as we are with
The Zoom system. Say something, yes,
Yeah,
you will come on the
yeah.
screen.
So that's why only Pablo can talk during the
No, if any participant says something,
literally like 10 minutes ago. Actually works very well. The big screen. Okay.
since we have the same, as we are with
the Zoom system. Say something, yes.
What is this?
Yeah. So that's why only Pablo can talk during the
It's coming. The
Yeah.
chat is coming.
Look. Congratulations to the Brazilian
What did they say?
Society.
Regards from Algeria.
Yeah.
Yeah.
Hello, Ipe. Very nice to see you.
From India. Russia,
Yeah. Hi,
Everywhere,
Prof.
huh?
Pablo.
Germany. Something, yes.
What is this?
So that's why only
I
Pablo
think
can
this thing
talk.
was very nice. huh?
Yeah.
1,500, 1,300.
Yeah, congratulations.
Ramesh,
Not the good angle, right?
Regards from Algeria.
Yeah, Pablo.
you are second, I guess. Are you?
Let's put
Like,
it-
Yes.
with-
from India.
Igor, hola.
Hola, cabrón, ¿cómo estás?
¿Cómo estás?
Bien. ¿Comí paella, güey?
Are you in the on-call room? You were sleeping there.
This is my office.
Yes.
Igor,
Yes.
hola.
Who is talking?
Someone is double connected. This is why we have this
Echo.
echo. On-call room is someone with two computers or the phone.
No problem, there'll be other conversations and
Yeah, but I hope maybe when you start speaking, they would like it's blocked.
you can mute it.
Yeah.
Yes, mute. Someone is double connected. It's you, Igor. Igor. It's
Yes.
You have two devices maybe there.
Oh, it's probably myself. Yeah, I was testing the YouTube link. I just closed
Yes,
it.
that's why we could hear the echo. Make sure that you only have one device connected. Otherwise, we will have
It was
this
only
echo.
one device, but it was just testing the YouTube link to see if it was working.
Okay. And is it
How
working?
did you know?
Yes.
How did
Thank
how
you.
did you know, Pablo?
Say again.
How did you know it was Igor?
Because I was muting all of you, and once I
Oh, I
mute
see.
Igor, I checked that the echo disappeared.
He did a differential
Okay.
diagnosis.
I'm talking with John Bennett. He's trying to do something with the YouTube.
Pablo, is my voice clear now?
Yes, as usual.
Yes, I had the mic, but it was not connected, so I just now connected it.
Well, it looks
Yeah, it's
like
much better now.
it looks like you are in a cave and you are the devil.
He's in a man cave. Yeah, he's in a cave.
The cave is my office.
Yeah, lines done.
So, Imad,
Yes.
is the schedule as you fixed? Is the same order of
The
speakers?
same order. We are not going to change the order. It will be, everyone knows his time and sequence.
Perfect.
Would be easier for everybody.
Great. So we are missing Salman and Ek.
Salman, Ek, Giovanni,
Well, Giovanni has not talked today, but yes. And Henry and Sanjeeva.
and Sanjeeva. Sanjeeva, he said he will join a little bit
Okay.
before the 3 o'clock.
Okay. Okay.
And it's up. I don't know whether Santarius is coming today or not.
Okay. I hope so. So I am just fixing some issues with John Bennett. I'm back.
Yeah.
Cuma masih bisa bikin mute sama dia ya Kak? Dia bisa bikin mute? Hah? Operator ya? Jadi kita dia mute berarti dari dia ya? Jadi dia sendiri kalau memang dia, tadi kan
Imad,
Yes, man.
do we have everyone for tomorrow? Roy is here, Igor is here, Victor is here, Rames, Kirolos.
Yeah. Yeah.
No, Ramesh Kirilos, he will be.
He wouldn't be?
I am.
He might come. No, Ramesh is not you, it's Rames Kirolo.
Kirilos.
Kirolos, so he's out?
No, we don't know. Whether he will join today, I don't know. But he's for tomorrow, he's coming.
He's coming, okay. Johnny is coming. Miguel
Miguel is coming.
is coming. Thomas should be coming, and Eka is here.
Nobody is missing.
Nobody is missing.
No.
Ek, have you spoken to? I have spoken to Ek. He should join in a minute.
Wonderful. I think all
Kasper.
of them yeah, Kasper, he will join today. Yeah, he said he prepared his talk.
Henry will be, you are here. Sanjeeva will be. Good.
Everything okay?
Yeah.
Yes, everything.
Yes.
Hello, Tom.
Hey, how are you?
Good, and you?
Hello to everyone.
Hola, Tomás Antarius.
Pablo, hola.
¿Cómo estás?
Muy bien.
Muy bueno. Is that sunlight in Cambridge? Or is that...
No, I've all the
Okay.
windows are blackened.
I was scared.
Yeah.
Hi, Tom.
Hi.
Hi, Tom.
Hey.
Itu mute sekarang, Tom. Itu mute. Aku mau ngomong. Wes. Hi, Tom.
Hi, Eka. All right. Nice to see you again.
Good to see you again.
So we are missing Salman
Salman, yeah.
and Ek.
Ek, he promised he will be ahead of 3 o'clock.
Okay, great. So Imad,
Yeah, I will, if the members agree to this, I'm going to give a short statement about the committee and the launching of this initiative and the purpose. And I'm going to just shortly, if you agree, I introduce each one of you, what is his position and from where he is coming. The alternative, hi, Vladimir. Vladimir, you heard me? Are you here, Vladimir?
we are hearing you. Vladimir is mute, but he can hear you.
You cannot hear.
Here am I.
Hi, Vlad. Okay.
Hi.
And the IP, I think, is mute.
IP is muted.
Yeah, I am generally
Okay, Roy.
mute, but otherwise now I am not muted.
Okay, now it's okay.
Everybody is on except Tanji. Tanji is, I think, muted. Tanji is muted.
Yeah, he can hear us.
I can hear you. I can hear you.
Okay.
We can hear you as well.
Hello, hello.
I
So
repeat
I'm
myself
organized
shortly.
to
I just
translation
repeat myself.
station.
I just repeat myself shortly. If you allow me, I will make an introduction to this course for a few minutes, and I go over the speakers from where they are coming and what their position. Unless you'd like to introduce yourself, it's up to you. But if you want to just to make a summary, Professor Benish coming from Karl's University, and he is the chair emeritus like me, and he is the chair of the neuroanatomy course. And I go like this, without expediting too much of our CVs. If somebody feels not very comfortable, and perhaps it's good for me as well, then we go one by one according to the schedule, and each one will present himself for 1 minute or less than this, and we go and finish it. Because I thought I'll present all the names for today and tomorrow, and then we have it ready tomorrow immediately to start with the course. Is this agreeable, or you have different thought about it?
Yep.
Perfect.
Fine.
All right.
Looks good, Imad. Looks good.
Okay.
So Imad, there is a bar down there for you and for the panelists and for the moderators. We have a chat and we have a Q&A. So we could announce that those ones who have a question related to the lectures, they should write on the Q&A.
Okay.
And just use the chat to communicate among themselves. But what we will read, it's only Q&A to select the questions.
Sure.
Can you say that again, Pablo?
Yeah, there is a down in your
Yeah, I
screen.
saw Q&A. And
There is chat and Q&A. So we will have 5 minutes after each lecture for discussion, and it will be based on the trainees' questions. So the questions should be written. This is an announcement we should make for them. The questions should be done in the Q&A option.
Okay. Okay.
This is what we will read.
Now, the other thing, students, all of us are here. Please don't encroach on this 5 minutes during your presentation. Leave that 5 minutes for the questions. So try to finish by 20 minutes, including your videos. We have to cut you and to give a chance to 5 minutes, because this is the whole purpose of online courses. Okay?
Okay.
Okay.
So.
Hi, Sanjeev.
Pablo, how are you?
How are you, Sanjeeva?
I'm very well, thank you.
Hi.
Hello.
Ah, Sanjeeva.
Hi.
Sanjeeva, good to see you.
Where is him?
So how many registrants do we have, Pablo and Imad?
2005, yeah?
2005, is it?
Yeah, 500.
Yeah, will this session crash if everybody joins?
Well, the thing is that we don't know.
It's like World Congress.
So Pablo, the participants can hear us at the moment, is that correct?
Yes, they can. They can.
They are already asking how long they should wait.
I answered them that we are starting sharp in 20 minutes.
So this is the cheapest course you have, you guys, yeah? So a new idea coming upon the corona outbreak.
Yeah.
Imad and Vlad, some of my residents were asking if they will get some kind of certificate to attend the course.
Yes.
Be used as credits.
Pablo came with a suggestion, and go ahead, Pablo, and tell them about the certificate.
Well, the thing is that as what we do in our courses, we will have a certificate as a participant in this online course. Yeah, we will have.
Okay, and this will be sent to all the...
We will mail them along the week.
Okay, fine.
Once we finish tomorrow.
Yeah, which will clearly say how many hours, 4 hours on this day, 4 hours on the second day.
Well, it's based on how long time they are connected. We don't know if they are there or not.
Well, we can't time these things. There are 2,000 people.
But there is we are planning to have a feedback form tomorrow. So mainly those ones who fill it up, as we were discussing with Imad, they will get the certificate. If you all agree.
Okay, fine.
If you all
Yes,
agree.
absolutely. Yeah, it's fine. So there is a certificate.
We'll get a certificate.
Yeah.
Nice.
But you have to fill up the feedback form.
They are happy with the certificate, not with the course.
They're happy. Yeah, they only want the certificate, you know.
No, that's not true.
Were you joking?
No, you are distracted.
1,500 people.
So Vlad, you're on the big screen now, you see?
Am I?
Yeah.
I'm not. I'm twice
Yeah, no.
there. I'm with Roy. Ah, I see. Roy, you did it for everyone.
Yes, exactly.
Great. It's like cinema.
Exactly. And we connected it to the loudspeakers in stereo sound.
Yeah. Eka, you could have done it in Lipo Village, in that cinema of yours.
Sorry?
You could have done it in Lipo Village, in that cinema of yours.
Oh, sure,
Huge
yeah.
screen.
3D, yeah.
Imad, we need to save 30 minutes in each day.
It shows the people.
Yeah, you're proud of
Imad,
Yes?
we must save 30 minutes each day.
What do you mean? We have to cut
We are
more?
30 minutes longer than
That's not true.
No, we made it 25 minutes.
25 minutes.
So it saved already the 30 minutes.
Then it's okay.
So 20 minutes lecture and
Yeah.
5 minutes question
5 minutes
and no
question.
discussion.
Right.
No discussion.
Right.
We sent it to everybody yesterday.
But I don't think it's gonna work. Who is the organizer?
Ek is here. Wonderful.
Yes, this finally worked. Good morning, guys.
Morning.
Morning.
Welcome.
Good afternoon for us.
Afternoon.
Yes.
And I think for Eka will be evening in Indonesia.
After
Believe me,
breakfast. Just after breakfast.
When is your breakfast? It's soon, yeah?
Yeah, it's just breaking fast here.
Oh, I see.
Yeah.
And what about you, Eka?
Sorry?
Eka is getting breakfast and Kasper.
Oh.
Well, yeah, I just came from my morning cup of coffee. Number 2 is here, just in case I fall asleep. So everything is fine. Guys, it's wonderful to see you all.
Same on our side, yeah.
Same on our side.
Nice to see you, Ekkehard.
Did you all practice? Did you all sleep well?
Yes. Yes.
Not excited like schoolboys. I am.
We are always.
Yes, yes. Now, Imad, you have to tell us briefly again, how do you put in a sharp stop in case we become too Shakespearean?
We have a hammer.
You have a hammer. Does it show up on screen and knocks out the person?
No, it shows only the offended person on his head.
Okay.
Maxwell.
We gave the privilege to the moderators to do that, so they can block you. All of a sudden, you see you are talking, but nobody is hearing you.
All right.
Very simple. This is easier than a meeting.
I think so. I think so. Well, we still have like 30 minutes left. Is there any other business, gentlemen?
It's not 30 minutes. It's 15 minutes, I think, left.
15, okay. 15.
Yeah. No, actually, the only things we mentioned while you are not there, I'm going to give a short presentation, I mean, a few words, and present the speaker shortly, and then we proceed. The moderator will take over, and they are the one who control the scene, control the questions. There will be question and answer for 5 minutes, and the attendees and participants, they will write it. I'm hearing echo. I hear you.
That is all wonderful. We're all geared up. And do you have sort of a little score bar on the side that shows you how many people are tuning in and out? Is anybody keeping the stats for us?
Yeah. We are going to. We have meantime 2,500
Crazy.
participants.
Is anybody going to record this for us in case we need it for the posterity?
I think so. That would be. We send the.
John is probably doing it. John Bennett.
Excellent.
John Bennett.
It will be transmitted. It's already on YouTube now.
Well, maybe I can run it at the same time myself on the YouTube channel, and then I have it in stereo.
No, then it will be, the voice won't be clear. If you run two systems, it won't function. We just test it.
Good. Give me 1 second. Hospital duty is calling, as always.
Igor, how are you?
Good. You know,
how is the COVID in France? Are you getting better?
It's getting better in this region I am. You know, it was one of the last touched regions. It's very calm now.
Yeah.
Yesterday was the first day we were allowed to get out of our industries. I didn't stop anyway, but my wife was at home with the kids.
Okay.
So Igor, you are not France, not Brazilian anymore?
I will always be Brazilian. With a lot of pride. Yeah.
I think all of us became international.
It's so nice to see you.
I'm just checking, each one of you is not in his home birthplace, I mean, and which is logic.
Yeah, many of us are not in our native country, right?
Perhaps Victor. Victor, you are muted.
Hello, Imad. Very nice to see you here.
Nice to see you too. We were talking that most of us, we were born somewhere and practicing somewhere, we're living somewhere. I think you are from the same place where you are born. Yeah?
Yes, of course. Yes, I was born in Mexico City and I am living here.
Okay.
Yes.
Imad, can I just ask, do we know the people here on the panel? Who is Chinese translator #1 and who is the one in the right lower corner?
This is Dr. Tanji is there, and we have two translators with him.
Perfect.
Dr. Tanji, we invited him today to be
wonderful.
part of the translation, but the next meeting, hope he was interested to join us in one of the conferences.
No, that's perfect. It's just because of the concerns about special guests at Zoom sometimes logging in and you have them on the screen, although they may not be invited. If that happens, you just have to be courageous, shut it all down and log it back in a minute.
Yeah.
Because we had heard occasionally that can turn sour.
Right.
But I'm not worried. It all looks good.
Before we start, I like to give the credit to both of them, Pablo Gonjalez and our colleague from he's from Oxford.
Ramesh is
Oxford. Sanjeeva. because Sanjeeva was actually the initiator who came with the suggestion to me, and I bless it. And Pablo joint venture, and both of them, they did marvelous jobs, helped me in striking this one, and I hope it will be a success. We are planning to get the feedback, and we share the feedback in one of the events together, so everyone knows what was the outcome of this meeting.
Yes, congratulations for Pablo Gonjalez. Now we have almost 400 participants in this webinar, but I think in YouTube there are some more.
It's not 400, Victor. It's 2,500.
2,500. Wow,
Yes.
it's incredible.
I almost put on a tie, almost.
Merah putih digeser dan kita. Apa teh? Anu yang lampu nih. Kudu ini kayak klepet-klepet. Ini karena anu ya, file nya anu. Aja kowe aja yang ngono kita. Ya, kok begini ini. Nah, semua kita.
So Imad. Imad, can you hear me?
I'm hearing you, yes.
Yes, I think I have the possibility to mute all the panelists once the speaker starts with the talk. But
Wonderful.
we should make sure that once someone starts his talk, the rest of the team should mute. You should be muted, because otherwise, if you have some noise in the room,
Destroy the
it will disturb a little bit. Yeah. So just a reminder.
Imad.
Yes.
You need a light in front of you, so then people can see you more clear.
Like yours, Eka.
Yeah, Imad, you know this just like in beyond the cloud. Sorry, Imad.
You don't see me well? I'm trying to find the best light for this room.
That's fine, but just like maybe you are in the top of the Burj Al Khalifa, so there's a cloud there.
Sorry, I think your fasting is confusing you. I am not at Burj Khalifa because I'm in Riyadh, Saudi Arabia, not in Dubai.
Okay.
All right.
So I am gonna share in the chat for everyone the YouTube channel, because we already have 500 people, and those ones who will not be able to enter the Zoom, they will have the link to join us in YouTube. Just in case you get any message from your trainees or whatever. I don't know if you can see the chat. I just shared the link.
Yeah, we can see the chat, Pablo.
Don't click on the link, because otherwise you will have the YouTube channel open and also the Zoom, and that's not gonna work. It's just to share it. Thank you, Nilufar, to confirm that you can see the link.
Pablo and Imad, for tomorrow, we are going to connect using the same link.
Yeah, yes, yes.
Pablo, is that automatically go to the tube when the link cannot?
Say again, Eka?
When participant cannot enter the Zoom, will be automatically go to the.
They should get a message informing them that the meeting room is completely full and they can access us in YouTube channel.
So this maximum is 1,000, the Zoom.
This one is 500.
Sorry, why 500?
500.
Oh, okay. So next time you have to order 1,000.
Yes, we are discussing that.
Yeah, will be great.
Is there a way to know the countries, how many countries, where the participants are coming from?
I check it and it's like 93.
93 different countries? Okay.
Pablo, I think your 500 is wrong because I already have 517 participants here.
I'm happy I'm wrong.
More than 500.
Yeah.
Yes, I'm so happy that I'm wrong. But you're right.
So maybe yours is 1,000.
I think it's 1,000. I think it's 1,000.
Let's check it.
Very good.
So 1 minute.
So hello to everybody. Gianni.
Hi, Giovanni.
Hello, Giovanni.
Ramesh.
And Ramesh is there as well. Wonderful.
Ramesh, hello.
Giovanni needs to unmute himself.
Johnny, unmute yourself.
Yes, I am at home.
Yes. Ramesh.
Yeah, hello. Yeah,
hello, Ramesh.
Hello, Ramesh. Hello, Giovanni.
Yeah.
Greetings from Mexico.
Oh, nice to see you. Nice not to meet you. See you.
Ciao, Giovanni.
Yeah, hello. I'm just looking, just watching what is going on today to be prepared for tomorrow.
Wonderful. Okay. You are most welcome to stay all the time with us, Giovanni. We welcome everybody. You are on the faculty for 2 days in the principal.
We are missing Salman.
Salman, we sent him several reminders, he said, and he has been in communication. I hope he will open his,
So it's time. We have 520 people, and I think it's 500 the limit, because we also have like 100 people in YouTube joining us.
Very good.
Okay, I think I will start. Ramesh is not there. Carollo is not here.
I can see Ramesh.
Now he is on.
He's gone off.
And Roy is there, yeah, with his team.
Yes.
Yes. Roy is there.
Sorry, can you come back again? How many participants do we have?
2,500.
I think I will proceed now with opening the course on behalf of the World Federation of Neurosurgeons and the Neuroanatomy Committee and the faculty of this course. I'd like to welcome all the participants and young trainees and practicing neurosurgeons to this course. And on behalf of Professor Vladimir Benish and myself, we are co-chairing this course. And one thing I have to tell you that this COVID And pandemic has cost us a lot of social and academic decline, but we try to compensate it. My appreciation to all the faculties that they were prompt, keen, and very diligent to support this course immediately without a delay. And 18 masters from around the world faculties that will join this course on 2 days, each for 4 hours, starting sharp, as we said, 3 Greenwich Mean Time. Each speaker will have 20 minutes for his lecture presentation, including short videos, if any, and we leave 5 minutes for questions that will be controlled by the moderator. And since the number is very big of the participants, exceeding the 2,500, we elected to have this question written under the question and answers, and the moderator will select 1 or 2 questions, viable question for each speakers or one of the speakers to answer them, and we try to finish on time. Without further ado, I'd like to present the speakers. Start with Professor Benish. He is the chairman emeritus and the professor at Karls University, First Medical School. He is well-known internationally for his excellent work in the skull base and vascular surgery, and he has contributed books and publications. Yeah, Dr. Benish, you show yourself, okay, on the left lower corner. Professor Ekkehard Ramona, I always have difficulty pronouncing his family name, and he is a professor of neurosurgery at the neuroscience department in Siloam Hospital and a dean of the University of Pelita Harapana in Indonesia. He is known for his contribution into vascular and skull-based surgery. Professor Giovanni Broggi is the vice president of the International Society of Minimal Invasive Neurosurgery, a chairman emeritus and of the first neurological Pesta University in Milan, with non-contribution skull-based vascular, functional neurosurgery, and epilepsy surgery. Professor Kazadi is a professor and head of neurosurgery at the University of Zimbabwe, known for his contribution to promoting neurosurgery in Africa. Professor Ramesh Nair is a consultant neurosurgeon and professor, and he is at the Charing Cross Hospital, Imperial College Healthcare System in England, known for his field expertise in the field of pituitary and skull-based surgery and vascular. Professor Ramesh Kirolo is a senior consultant neurosurgeon at the National Neuroscience Institute in Singapore, and known for us as a part of the Cambridge Group University, with expertise in neuroanatomy and skull-based surgery. Professor Thomas Santarios, he is from Cambridge University, and he is known for his contribution to neuroanatomy education around the world and in England, as well as his expertise in skull-based and vascular surgery. Go on the other. Dr. Ekkehard Kasper, consultant neurosurgeon and professor of neurosurgery, known for us from Boston Harvard University in US, and he moved recently to McMaster to head the section of neurosurgery. Professor Sanjeeva Jeyaretna is a consultant neurosurgeon and professor of neurosurgery from Oxford Health System and Oxford University, known for his contribution to skull-based surgery and neuroanatomy, as well as vascular surgery. Professor Aipe Sherian, he is the director of the Nobel Institute of Neurosciences, and he is a catalyzer, and his contribution in skull-based surgery and vascular surgery is well known. Professor Victor Hugo Lopez from Mexico. He has tremendous work on neuroanatomy and skull-based surgery and vascular neurosurgery with contribution to international and national events. Let me see if I left anybody. The one I left, perhaps they are not there. No, I missed one, Professor Voy. Professor Voy, he is in Lausanne. He is Deputy Director of the Institution of Neurosurgery, and he is the head of skull-based surgery with a grand contribution to epilepsy and skull-based surgery. Did I miss any of you? I don't think so.
Did you
I
miss
think
Pablo?
the one.
You didn't.
Pablo,
I should.
Pablo, yeah.
Yeah, I should
left
introduce yourself, Imad.
Yeah. Before I introduce myself, I'd like to introduce Professor Pablo Gonjalez Lopez from Alicante. He is working at the University Hospital with a great contribution to neuroanatomy, and he is an essential member of the neuroanatomy committee of the World Federation. And I have to give him credit and Professor Sanjeeva for the initiative to support this online course webinar with a great effort and job. Myself, my name is Imad Kanan. I am Chairman Emeritus and Professor of Neurosurgery at King Faisal Specialist Hospital, Al Faisal University in Riyadh, Saudi Arabia. I leave the phone now. Two speakers, let me introduce them for tomorrow. We have Professor Henry Schroeder. He is a professor and chairman from the Department of Neurosurgery at the University of Greifswald in Germany. Is known for his work in endoscopic surgery. And Professor Salman Sharif, he is the head of Neurosurgical Society in Pakistan and the head of Neurospine Committee of the World Federation. He will be speaking sometimes today. I end my presentation and I hope that the moderator, Professor Gonjalez and Professor Sanjeeva to proceed with the session.
Yeah, thank you very much. Thank you for the lovely introduction to everybody. It's a great pleasure to start off the session today with Pablo Gonjalez, who is a real expert, as we've discussed in neuroanatomy. We're talking about white fiber anatomy, which is an area of real interest for him. Pablo, thank you very much for joining us today, and we look forward to your talk.
Thank you. Can you hear me properly?
Yes.
So thank you, Imad, for creating this experience. This is the first one, and if it works, I really hope we can do it in the future. And well, one of my passions in our specialty, it's the study of the neuroanatomy in general, but more focus on white matter fibers. So I'm going to share part of my work with you. And the limbic area is something that I really wanted to understand when I was a trainee, because it's something complex, not only in name, but mainly in understanding how tumors in that area are growing. And I cannot start this talk without thanking whom I consider my mentor, who is Professor Ture. I had the privilege to stay in his beautiful hospital and microneurosurgery lab for 1 year, and that was a fantastic period in my life who really changed my practice. So I highly recommend all of you to spend some time in the lab, because after staying in the lab, you can look at an MRI and see completely different things than the ones you see before. So first concept is to understand the word limbus, and the limbus means the edge. So the limbic system could be considered the edge, the medial edge, in fact, of our brain hemisphere. So this is the first concept I want to introduce. And the second one is why these areas are on the edge of the hemisphere. And this is something amazing. I also recommend you to study the phylogenetic evolution of the CNS, because this is a fantastic way to understand how the tumors are being located in these deep regions. So in 500 million years, that the brains of the first animals, the fishes, became in what we have now. And if we analyze the evolution of this CNS growing, we will see in green areas, the limbic areas, the archipallial and some of the paleopallial regions, which with the development of the CNS are being pushed, as you can see, to the medial aspect of the hemisphere. And this movement to the midline is mainly due to the huge growing of the neocortex. So in this picture, in this coronal cut, we can see in red the neocortex and how these limbic areas have been pushed to the medial aspect, to the interhemispheric fissure, and also in the basolateral part where the parahippocampal regions are staying. So this evolution of the CNS is very important in order to understand why we have these limbic regions in the midline. So in these areas, we can find completely different tumors, mainly gliomas, low grade, high grade, even some mets in these regions. And my point is to try to share with you how I think about approaching, why I do the approaches I'm doing to reach these regions. So we will divide them in the cingulate area and the parahippocampal region. So you can see in this picture, the subcallosal region, the cingulate gyrus, the isthmus, which is a very important part of the limbic system. It's a pivotal point in between the cingulate gyrus and the parahippocampal gyrus, which goes to the basal aspect and a little bit lateral because of the growing of the diencephalon in between both parahippocampal regions. So something important about the limbic system is not only this deep anatomy, this deep located anatomy, but also how the fibers are arranged. And they are mainly arranged like belts. They are completely different to the fiber systems we do have related to the telencephalic neocortical regions. This is very important. Another important thing is the vascularization of these regions, which comes directly from small perforators coming from the main trunks of the anterior and posterior circulation systems. So let's go about to deal out how I approach these regions and why, and mainly the choice of the approach should be based on anatomy. So we must consider go, respect, and perform. We have to go through anatomical corridors. We have to try to respect the surrounding structures, and we have to try to perform an atraumatic manipulation of the brain tissue, which is in between our tumor and our corridor. How we go through anatomical corridors safely with neuroanatomy, this is the key. How we try to respect the surrounding structures, understanding the tumor biology, how the tumor is growing and how it's being fed, and how we do perform a traumatic manipulation, choosing the proper approach and positioning properly our patients. But two very important roles in my mind to approach intrinsic brain tumors is to enter the sick functional unit, which means the most cortical aspect of any given tumor, and always try to stay within the tumor. And these are two concepts that I got from Professor Touré and Professor Yazargil during my stay in Istanbul. So let's go through some practical cases in order to highlight all these concepts. And this is a patient who we received 2 weeks ago in our department. He came with a headache and some personality disturbances, and you can see this low-grade glioma, how it's growing mainly in the subcallosal area. So first step is identifying where the tumor is growing. Subcallosal area is in the midline, it's the most basal and anterior part of the limbic system, just below the rostrum and genu of the corpus callosum, as you can see in this sagittal section. So in these cases, I like to, as I told you, to approach directly to enter the cortex in the point in which the tumor is more cortical, more superficial. So for that, I place the patient in a kind of semi-lateral position. It's a supine position with the head rotated slightly to the ipsilateral side. So you can see here the midline, and we, first of all, before opening the dura, must identify some veins, breaching veins, and the idea in most of the cases is to try to respect them. Sometimes the venous anatomy is very capricious, and we can do an opening like this to work into two windows. So we are going basal, and then we enter the tumor in the most cortical part. So another important aspect is that this tumor was being pushed to the contralateral side. So this is why we can open the falx in this part and perform our subpial resection. Then we go deep and we want to identify the chiasm, that's the optic chiasm just below and behind the tumor, and also both A1s and A2s. It means that we have reached the most posterior part. Then we move upwards to enter the frontal horn. In this case, as it had hydrocephalus, we perform a septostomy. And as you can see, we are staying inside the tumor. That's the key in order to understand how these gliomas can be resected in the proper way. This is the post-op MRI. We had some doubts about the total removal, but the diffusion said that we had some ischemic areas, and we were quite happy with this result. He was discharged just last Friday. So this is a message. Not only think about the tumor, where is it located, but also in our corridor. And in our corridor, maybe we can find some of these bridging veins, because we have to approach the interhemispheric fissure. So it's important to try to respect them as much as we can. Let's go to this second case. This is a tumor. This is a GBM of a 53-year-old male who had some personality disturbances. And this case is mainly situated in the anterior cingulum. So this is why this tumor is growing like this, because the cingulate fibers are wrapping around the genu of the corpus callosum. So again, this is what we use in these cases, supine position with the head slightly rotated. And I took this very, very interesting positioning from Professor Mike Lawton. He was approaching basal ganglia cavernous malformations like this. So with this approach, we will be able to release some CSF from the pericallosal cistern and to have the aid of the gravity to create our space in order to reach the contralateral aspect. So this is a interhemispheric contralateral transfalcine approach in order to reach this contralateral cingulate tumor. Again, we try to respect the venous anatomy when we are opening the dura. This is something mandatory, in my opinion, and to create as much space as you can. Releasing CSF will help us, and then we can open the falx, protect the ipsilateral hemisphere with some cottonoids and with the falx itself, and then we go inside the tumor. So in the most cortical part again, with the aid of 5-ALA, we can do that, and you can see how we are identifying the cingulate sulcus. Let me show you one of the gaps of this contralateral approach, which is that we cannot access, we have no direct control of the superior part of the tumor, of the roof of the tumor cavity, but with the aid of the speculum or even an endoscope, we can reach that area. So you can see here how we have respected the cingulate sulcus and removed this anterior cingulum glioma. This is the aspect that the ipsilateral hemisphere has. After the removal, we can replace the falx, here we have it. If not, we can place some spongostan and close the dura. And with this contralateral approach, we can reach the most lateral part of these cingulate gliomas. Let's move more posteriorly. And let me show you this case, which is still in my ward because he came last week with some progressive hemiparesis due to the COVID. He was scared to go to the hospital, and he had some 25, 30 days progressive hemiparesis, and he came to the hospital in a very, very, very bad situation. So we did surgery on Friday, and let me show you that this tumor is mainly growing in the central aspect of the cingulate gyrus. So we can approach this tumor transcortical or transsulcal through the convexity because the tumor is quite close to that. But if we follow the rule of approaching and entering the tumor through the most cortical part, we will understand why. And let me show you the tractography. You can see in yellow the corticospinal tract. So if we go from lateral, crossing this very thin layer of cortex, we will probably ending damaging this corticospinal fiber tract. So this is why I prefer to go interhemispheric, IPSI or contralateral, wherever you feel more comfortable with. I prefer contralateral in this case. So this is the scheme of the surgery we can perform for that. And we always perform this venography in order to check that the contralateral window is going to give us a good access to the interhemispheric fissure. So we can place in the contralateral side, which means in the side where the tumor is, some electrodes to check the corticospinal tract continuously during surgery. You can put it epidurally, as I did in this case, and then we can access the interhemispheric fissure in order to remove the tumor. You can see in the post-op T2 coronal how this very thin layer of cortex now is much, much, much wider, and the corticospinal tract is right there, and we check it with electrophysiology. Let's move a little bit more posteriorly, and this is not a glioma, this is a metastasis, which is mainly located, as you can see in the sagittal cut, in the posterior part of the cingulate gyrus. And this is a very important area because here the cingulate gyrus is going to join the isthmus and going to go a little bit lateral. But here the most important thing is to consider how close this tumor is of the so-called paracentral lobule, which is part of the motor and sensory strip. So this is what we have to identify. And again, in this case, I decided to go contralateral to have a more wider control of the lateral aspect of that tumor. So again, take your time to release CSF, to disconnect the veins, respecting them, and to create space enough in order to expose the falls. So once we have a good window, we go in the interhemispheric fissure. Sometimes we check it with the ultrasound or with the Doppler, and then we open the falls. So here we are opening the falls. We can see the tumor already there with the paracentral lobule. So the ascending or distal ramus of the cingulate sulcus is right there, and the tumor is coming to the surface. This is the key, to approach the tumor from the most cortical part. So we are dissecting the arachnoid so as to preserve the paracentral lobule, which is just above, and that's the metastasis. So once we have space enough, we start debulking. And again, in this case, it was quite cystic. We can use the speculum so to check that the superior part is quite clean. And this is what we are doing here. So let me show you 24 hours later, how after the decompression and removing the tumor, the layer of cortex, which was 1.2 centimeters, now suddenly became 2.6. There is a lot of white matter fiber tracts in that area that we must try to respect. Let's move more posteriorly and basally. And this is a 45-year-old lady who came with some headache, and we had this MRI, and you can see here an intrinsic tumor mainly located in the so-called isthmus. This is a very important area because, as I told you here, the cingulate gyrus, which is purely in the midline, becomes the parahippocampal gyrus, which is a little bit more basal and mainly lateral because of the diencephalon in between both gyri. So this is an isthmic region, pivotal point in between the cingulate and parahippocampal. And this is the limit for the interhemispheric approach. Everything basal here, we cannot, or we should try to avoid an interhemispheric approach. What can we do to approach the isthmus? We can go transcortical through the temporal lobe, through the occipital lobe. We can go subtemporal, suboccipital, or we can go even, in some cases, we can try to go supracerebral transtentorial. But in this case, we decided to, again, apply our rule to reach the isthmus from the interhemispheric fissure. Why? Look at this. This is the isthmus in the contralateral side. So if we put all the white matter fiber tracts that we will cross in case we go transtemporal, we will mainly damage all these optic radiations, which should be preserved because the patient was completely intact. So lateral position, ipsilateral approach, interhemispheric parietoccipital. Once we reach the splenium, we release some CSF, we place a cottonoid, and then we go directly to the isthmus. We start debulking this intrinsic lesion, and we want to enter the atrium. This is going to be our lateral limit. So you can see how we have entered the atrium. That's the lateral wall of the atrium. So those are the optic radiations, the fibers we want to avoid damaging. Once we remove the tumor, we have a nice view of the lateral ventricle temporal horn, and you can see how we are covering the visual primary area. Let's move to this different case. This is again a metastasis, and it's located in the parahippocampal gyrus. If you see the T2, you can identify the collateral sulcus just lateral to this metastasis. So this is not medial. As I said before, this is paramedially located lesion. So in these cases, we prefer to approach them subtemporally, or you can go transcortical. In this case, we went subtemporal so as to, again, follow our rule. So after opening the dura and drilling the middle fossa to have a basal exposure, we are going to release some CSF, and suddenly, just medial to the collateral sulcus, here we have this metastasis, which is coming to the surface. After debulking it, it was very easy to take it out, very comfortable. We did a nice removal. We were very happy, fast approach, safe approach, and we were happy with that result. We coagulated a little bit the dura, and then we can close it in a watertight fashion. I always place this spongostan layer. This is the post-op CT scan 6 hours later, and you can see what happened after this very, very easy, fast, and safe removal. Even if we are applying the best rules, we can have terrible complications like this subtotal hematoma. Well, let's move to this special case. This is a patient who came with headache and some memory disturbances, and we can see a GBM which is likely to be inside the ventricle. This is a purely hippocampal tumor. So you can see in the T2 how the tumor is perfectly drawing the anatomy of the hippocampus. So very important, once we decide the approach, to remove it and to identify our anatomical limits. Anteriorly, the ankle recess, posteriorly, the atrium, superiorly, the choroidal fissure, and inferiorly, the tent. Medially, we will reach the basal cisterns, which is the point in which we will stop removal. In this case, I decided to go through the temporal lobe. I did not apply our rules, so I did a transcortical approach because the tumor was quite vascularized, so I was scared of performing a subtemporal exposure. So anteriorly, ankle recess, superiorly, we will have the choroidal fissure. These are the basal cisterns with the carotid artery, PCOM and anterior choroidal. We are debulking the ancus. Here we can see the tent and the third nerve. I'm uncovering the third nerve, and now we have to be careful with the fourth nerve. This is the ancus, and you can see how these small hippocampal arteries from P2 are feeding this hippocampal tumor. So once we identify our anatomy, our limits, we are sure that we remove that tumor. So we can see here a nice view of the carotid artery with the posterior communicating going to P1, P2, and the third nerve coming from the midbrain. So this is our medial limit, the basal cisterns, and we are sure that we reach the most deep part of this hippocampal tumor with this trans T2 approach. This is an interesting case of an 18 months baby who came with seizures. And here we can see a complex tumor which is in 3 different functional units. It's located anteriorly in the temporomesial pole, also invading the amygdala and the head of the hippocampus, as you can see in the first axial image. So it's in 3 different parts. So in these cases, our nightmare is to respect the Meyer's loop that you can see is very related with this tumor. So in these cases, we don't do the classic Transylvian because it's invading the temporomesial aspect. So after splitting a little bit the fissure and releasing some CSF, I go through the temporal pole. I do a transplanum polare approach through the superior temporal sulcus. So once we go deep there, we will reach the medial aspect, the lateral aspect of the cavernous sinus wall. And that means that we remove the most anterior part of that tumor. Then we move posteriorly to the amygdala and finally to the head of the hippocampus. And the medial limit again is the pia. This is a subpial approach, so you can see the third nerve right there behind the arachnoid. And this is the head of the hippocampus, which is the last part of this surgery. So let me show you and summarize what we have been discussing: subcallosal region, anterior, central, and posterior cingulate, isthmic region, parahippocampal gyrus, and the ancus. But sometimes we can have tumors like this, which are invading different regions. This is a GBM, which was invading the ancus, the amygdala, parahippocampal gyrus, and you can see also the hippocampus, and even, as you can see in the sagittal cut, invading the isthmus. So we were discussing about a single approach to remove this tumor, and we couldn't identify it. So we decided to go in 2 stages. First stage, supracerebellar transtentorial, so sitting position. This is how we place these patients. Then we open the tent, we check with the endoscope if our exposure is good enough and orient ourselves. This is the ambience and crural cistern in front. And this is the parahippocampal gyrus, exactly where the tumor is growing. So we are applying our rule in this case. So we start debulking, and we can also use the 30 degrees endoscope with the CUSA so as to reach the most basal part of this tumor. Then we are trying to go upwards to the isthmus. We couldn't get it. That's the crura of the fornix, that's the choroid plexus. This is the lateral ventricle, just to orient ourselves. That's the pulvinar thalamus. And then we are moving to the most anterior aspect of the temporal horn. So in the lateral wall, you can see the optic radiations. So we were not able to take the isthmus out. So 2 weeks later, we perform an occipital interhemispheric transtentorial approach. We open a little bit the tentorium here, and we have the last part of this tumor located in the isthmus. So with the combination of these 2 approaches, we can remove the parahippocampal component and also the isthmic component. And what we are trying to preserve are the optic radiations, which are just behind that part, that cover of the ependymal layer. So this is the glomus of the choroid plexus. This is the crura of the fornix, which was the most superior part of that tumor. And this is the post-op in which we can see that we approached both areas with these two approaches combined. So just to summarize, these are the different approaches applied to the anatomy that we can use to approach limbic and paralimbic lesions. So we have to go, and we can go interhemispheric, ipsi or contralateral, doesn't matter, whatever you feel more comfortable with. We can go supracerebral, transtentorial to the parahippocampal regions, and generally we go transsylvian or transtemporal to the parahippocampal and hippocampal regions. But always keep in mind that we have to go through anatomical corridors, respect the surrounding structures, and try to perform anatromatic manipulation. So takeaway messages: limbic system is located in the medial aspect of the hemisphere in the interhemispheric fissure with a very special white matter arrangement. Never forget the relation with the falx, the interhemispheric fissure anatomy, arterial system, very important and mandatory. Try to respect the venous anatomy in case you can. Lateral exposure, in my opinion, is better because I have a better bimanual maneuverability, and we have the aid of the gravity to expose and open the interhemispheric fissure. And the contralateral transfalcine is a good approach in order to have a better control of the lateral aspect of the tumor, and we no need to deal with a sick hemisphere because we are opening the contralateral hemisphere. So thank you so much, and let me finalize with this slide in which we can see that we had a brain like the fishes, and mainly they have paleopallium. So they are mainly programmed with olfactory functions, mnesic functions, but mainly they react to fear and danger. Look at these two guys who were taking this fish. They catch it. They wanted a nice picture, but the fish has in his rhinencephalon the message to escape. So we did it, he did it, and the two guys couldn't control that one. And look at this guy, he has a huge telencephalon, huge neocortex. He wants to take some money from the bank, but then his movements are not coordinated, but he always has a good limbic system in order to escape. Thank you so much.
Thank you very much, Pablo. Thank you for an excellent talk. One of the questions that come up while you were speaking is they asked about, you talked very nicely about protecting the veins and draining CSF, and they asked about lumbar drainage. Do you use that at all in any of your operations?
Well, in these cases, I to be honest with you, I have never used it. I have thought it many times, but if you plan your surgery and your approach to have a wide access to any of the pericallosal cisterns, you can get CSF, release it. And if you cannot, in a few cases, what I have done is with the ultrasound, I just use the Cushing needle and took some CSF from the ventricles, which works very, very nice.
Excellent, thank you very much. I think in the interest of time, we'll move on to the next talk. So it's a great pleasure to have Ramesh Nair with us, who will be talking to us about his experience with transfer neurosurgery. Ramesh, thank you for joining us today.
Thanks, Sanjeeva, and thanks everyone. And I'm going to share my screen now. So I think there are participants from 19 countries. So I'll say good day to everyone. There's no point in saying good morning or good night, or it's different in different parts here. So similar to Pablo's talk, which is very anatomy correlated, I've wanted to talk about the transfemoral approach to skull-based lesions. These days, this is a very versatile approach for most of the skull-based lesions. And given the current outbreak, there's been some reluctance to perform this endoscopic operation, but even if you compromise by another approach, we will still have to go ahead with this approach with the right precautions. So various organizations and various national bodies have come up with their own solutions and various other techniques to prevent the spread of disease. But for the sake of this talk, I will talk about what we do in terms of the skull-based approach. First of all, a few basic things. The skull-based exposure will require some preparation. You need to have a good knowledge about the anatomy of the nasal cavity, the sphenoid cavity, and also the skull base. That is absolutely necessary. And any time you spend in the lab is not wasted. And one thing shown here is the nasoseptal flap, which has changed the practice of skull-base surgery. The main concern was about the leak and the delayed healing, but with this flap, we have reduced the incidence of such complications to minimum. And you need to have a set, and in my unit, I use the kit, the Kazadi kit, could have adequate bipolar, so scissors, and there are a variety of dural sealants. And in some cases, especially for vascular lesions, you may want to have additional capability to use the indocyanine green. Doppler is also a quite useful instrument during big operations, especially extended operations. And the nasoseptal flap is supplied by the sphenopalatine artery, but you need to make sure that you are not encroaching onto the olfactory epithelial area to avoid any loss of olfaction. And even if you do not have to take, even if you're not planning to take a flap in a standard pituitary case, it is a wise thing to remember that you may not know what's going to happen once you go in. You may get a major leak, which you may have to repair with the flap. And so what I sometimes do is to use something we call a rescue flap. I'm going to open up this video. So I'll show you what the rescue flap is. So essentially, this is the left nostril, and this is the left nostril, and we are just entering the sphenoid sinus. So this is the way area you can see the anterior wall of the sphenoid. This is sphenoid sinus cavity. I'm just sort of dissecting off the pedicle here, and we still can cut the mucosa here to access the middle of the sphenoid cavity. This is just moving the pedicle away. You're not actually creating a flap by cutting out the flap. You're just preserving it in case you need it. And if you don't need it, you don't have to use the flap. So that is what is meant by the rescue flap, and I'm doing it more and more frequently these days. So in a standard pituitary tumor, you stay within the cellular stage. You don't have to go outside your cellar, and often even if you have to remove a tumor which is extending above the cellular space, often you can stay within the tumor, avoid entering into the intracrine space. But some tumors are quite massive, and they can often involve vascular structures. Here you see the massive pituitary tumor is lobulating around the acorn complex, and there are multiple numbings. When you operate on this sort of tumors, often you will have to dissect it off, and the lesions become extracapsular. So you have to be ready to access that part of the tumor. So for example, so here, this is the cellular stage, and the standard practice is to always identify yourself with the midline. You always come back to the midline, and that gives you orientation. And this is the right side, and this is the left side. And here I'm curating out the tumor. This is a necrotic pituitary tumor. He came with symptoms of pituitary apoplexy, but when I operated, it's all infarcted pituitary tumor. So it's all curating out the tumor from the base at 6 o'clock, and then you go on to the other side and go for the anterior bit at the end. Here, you are curating out the tumor from the cellar, and but you have to use techniques to avoid entering into the arachnoid space. So show you what is the good practice is to use the patty. Here I'm washing out the cavity here, and here I'm holding up the arachnoid dome. There is still a bit of tumor left behind. So I'm just going to use my dissectors and curettes to curate out the last bit of the tumor, which is attached to the arachnoid dome. So you're using your patty as a dissector, and so you're not going to cause any arachnoid leak. And you can push it up, and you can also go inside the pituitary fossa to have a clear view of the remnant. Here, the last bit is taken out, and also watch out for the pituitary gland. So that is one important message I have to give. Before you start the operation, always look at where the pituitary gland is. On the MRI scan, try to identify the pituitary gland. So, and the instruments should be working in good way, and there are different techniques to arrange your monitors and the way you work with your ENT surgeon. And some units may not work with their ENT colleagues, but I prefer to use my ENT colleagues for the exposure, and often for follow-ups. They will be quite helpful in terms of following these patients. Some of these patients may get long-term nasal problems. Because you are operating through a narrow corridor, the instruments are straight shafted instruments. And you can understand, if you place your endoscope to one side, you often hit your instruments with the endoscope. We call it sword fighting. So in order to avoid, you need to have an ENT surgeon or your colleague who's driving the endoscope do it in a harmonious way. They have to, it's like a dance or like a figure skating or like a synchronized swimming. You have to be adaptable for each surgeon's maneuver. And one way to avoid sword fighting is to try and shift the center of action to one side rather than keeping it in the middle of the screen. And navigation is quite useful, especially for complex lesions of the skull base. And some of the pituitary, some of the sphenoid sinus is quite smooth. You don't have any septation, but sometimes you can have very multi-septate pituitary sphenoid sinus, which can cause confusion in terms of the anatomy. But the main thing you have to remember is that the carotid impressions are on either side, the left and right. And if you know the landmarks, you should be able to avoid damaging these structures. Because one of the main nightmare or complications related to a transvenous operation is injury in the carotid, and that makes a very bad day. So the way you to avoid that, you have to keep that complication in your mind all the time whenever you are operating on skull-based lesions. The best way to do, even though you may have navigation, the best thing is to always get your landmarks right. Here you can see the midline. So you keep your view with the 6 o'clock to 12 o'clock position on the screen, and all the time come back to the midline. So then you know where you are away from the carotid and the important structures. You can see the optic nerve impression here, and the paraclinoid carotid coming up to here, the cavernous sinus carotid, and then it forms a loop, and then you have the paraclival carotid. The two most common positions where you get damage is the paraclinoid carotid and also the clival carotid, the paraclival carotid, especially when you're drilling. So it is important to have some interventional backup if you ever get into trouble. Especially if you're planning to do big skull-based tumors like chondromas or meningiomas or even big craniopharyngiomas. Here, this lady had a meningioma, which we took her to theater to do an endoscopic approach, but unfortunately, there was a intraoperative hemorrhage from the carotid near the paraclinoid carotid, and she was taken to the intravascular tube to get it embolized with the balloon. And then a week later, she was taken back to the theater for resection of the tumor. Here you can see that balloon is staring at you from that hole in the carotid. So this is important to know that you can easily get a carotid injury. The other place where you get damage to the carotid is when you drill the clivus, especially for invasive tumors. I'll show you one video where there were some near misses where you could have easily injured the. So this is an invasive pituitary adenoma where I'm drilling near the. So this is the pituitary fossa. You can see my cursor moving. That's the sella with the tumor. But also this tumor is invading the clivus and also the posterior clinoid. So I'm trying to drill off the carotid, and this is. I possibly misjudged the impression, and I probably was too close to the carotid. And also after a while, you can see, I mean, the carotid eventually was exposed here. That is the carotid there. But it was intact. So these are near misses. So one always has to learn from such cases where you, especially around the paraclival carotid. So paraclinoid carotid and paraclival carotid. These are the two areas where you have to be careful, especially if you have to drill and expose that part of it. This is another invasive pituitary tumor with acromegaly. He's a young chap where I was drilling near the carotid to. So this is the. So you can see this here. So that is the carotid, paraclival carotid exposed by the drilling. I didn't have to expose it, but it was quite close. Sometimes you can have a more medial position of the paraclival carotid. And that carotid, you can see the pulsation of the carotid. So one has to be very careful when drilling the paraclival carotid. So just to emphasize this point, so this is your landmarks. When you do a transclival approach, your lateral limits are the carotid. And even if you are not doing a transclival procedure, you are drilling near the carotid, and one has to be really careful, use the diamond drill, and you just, if you have to expose that, you just have to make sure that you're not injuring the carotid, and thin out the bone, and then you can break off the bone. So craniopharyngiomas are good indication for extended procedures as well, and these are one of the ideal cases for endoscopic approaches. For example, this man came with a progressive craniopharyngioma. It's a high-functioning individual with a visual compromise, and the approach involves extending the cellular opening into the tuberculum. And most of the craniopharyngiomas you can approach it through the transtubercular approach. Even you don't have to go beyond or more anterior to tuberculum. You can always restrict your bony resection to the tuberculum area, and then you go in front of the pituitary gland. And in cases where the tumor is mostly anterior to the pituitary gland, you can leave the pituitary floor intact. This is where you dissect off the craniopharyngioma from the other structures around. Sometimes the craniopharyngioma can be quite adherent to the structures, including the optic chiasm. For example, this is a young police officer who was operated 2-3 years ago. You can see the craniopharyngeal wall is quite thick, but it's adherent to the structures. And there will be structures like superior hypophyseal artery coming from the carotid artery going towards the optic chiasm. You can see the optic chiasm here. And there will be the vessels like this, fine vessel, which will be supplying the capsule, probably may not be supplying it, but maybe coursing through it. One has to be really careful to avoid injuring those vessels. So this is a part of the optic chiasm is stuck to the capsule here. So one has to be really gentle. Here you can see how much of adherence there is. That one is best to leave it alone rather than risking the microcirculation of the optic chiasm. The ACOM complex you can see really well here. So that is the craniopharyngiomas which one has to be careful about, and he remains disease-free after many years. Some of the craniopharyngiomas are often difficult to resect completely. For example, something like this, when the craniopharyngioma is attached to the medial wall of the third ventricle. All you can do is to remove the solid part of it, but try not to disturb the medial hypothalamic walls. And often you can find that the craniopharyngium is attached to the infundibular stalk, and that becomes a problem. It's ideal to avoid pituitary stalk injury, but if you need a complete resection, in many cases, one may have to consider transecting the stalk. And I do that as a second stage. I don't do it primarily. Only if it comes back, I tend to do elective resection of the pituitary stalk and knowing the content in the patient beforehand. So this is I mentioned about the superior hypophyseal branches, and the pituitary stalk also is often at preservation ideal. And so when you operate on chordomas and chordosarcomas meningioma to the clivus, the vertebral artery perforators are quite important. The way you use your suction and your instrument to peel off the tumor away from the perforator. You can see a perforator here. So this is the meningioma which was being debulked. And this is a man who had a large chordoma which was resected 3-4 years ago. So you can see all the perforators are preserved here. And by the side of it, the sixth nerve was going by the side of it, just here. So it's another young man with a craniopharyngioma. So some of the lesions, like arachnoid cyst, this is a lady who came to me after being followed up for an arachnoid cyst for many years by a pediatric hospital. But when she became an adult, the cyst started growing back, and then she was getting visual problems. So eventually she wanted to have the surgery done. Initially, I did it through the endoscopic approach through the nose to drain it. But the problem with arachnoid cysts is that they often recur in spite of you draining it. So for her, I had to go through the head to drain it. In spite of that, she again leaked when I had to go back into the nose to repair it. So sometimes you need multiple operations for these lesions. For at this point, my strategy for arachnoid cyst of the stellar and suprastellar space is to try and do a standard supraorbital mini craniotomy and drain the cyst and marsupialize the cyst as much as possible. So another young man, a librarian with an arachnoid cyst, where I did a supraorbital approach, not then endoscopic approach. So it's tempting to do endoscopic approach and transphrenoid approach for these lesions, but I prefer not to these days. This is a young guy, an investment banker in London with a Rathke cyst, which came and somebody drained it initially, left some tissue there, and they promptly came back. Then I had to excise the lesion to an extended approach. You can see the clear space after excision of the tumor with the PCOM going up there and the basilar here, the P1 here, and the medial thalamic perforators are here, the mammillary bodies here, and the floor of the third ventricle set. But then this is a case where I left a remnant of the lesion around the infundibular stalk, but it came back 6 months, started growing. Eventually, I had to take him back to theater to reoperate. So when you go back after such operations, you can see how well the flap has taken up. But the only problem is that there is no landmarks. You have to rely on your navigation to get some idea where you are. So it is really possible to go back in such cases, but also can make it difficult. So then he remains disease-free, where I had to resect his infundibular stalk, and he has DI, which he's managing with DDAVP. Also have to be careful in some recurrent craniopharyngioma. This is a young chap I operated after he was operated many times before through transvenous route. After the operation, he woke up fairly late, sort of delayed fashion. His recovery was very slow for a few days in the ward. And you can see why, because his choroid nucleus shows some infarct on the right side. But he remains disease-free after all these years, because some of the vessels, especially recurrent cranios, some of the branches of the main perforators can get attached to these vessels, and you have to be careful. This is a man in his 70s who came 2-3 years ago with a large clival tumor. It's a chordoma, which was growing within 6 months' time. So here, the chordoma is being debulked through a transclival approach. So the limit of the clivus, the resection is on either side of the carotid. That determines your view. If you limit yourself too narrow, it really becomes difficult to dissect off the basilar and dissect off the perforators and also the cranial nerves around it. He had a pacemaker. I couldn't get a MRI scan initially. So the immediate post-op scan shows complete resection. But within 6 months, his tumor came back around the lateral aspect, and also he had multiple dissemination lower down as well. So chordomas are sometimes difficult, especially if their proliferation potential is very high. And some unusual cases where you can also use a transfemoral approach for aneurysms of the acorn complex. This is the case I did after clipping 2 aneurysms higher up. There's one aneurysm here, which caused the bleeding, and there was another one there. And these 2 were clipped through a transcranial approach when she came with the bleed. Subsequently, she came back when we had to treat this one. And that approach through an endoscopic approach. As you can see, these are more challenging operations, and you needed separate instruments to do that. So I think I'm reaching my time here. So I'm going to stop.
We've got a few questions. Thank you very much, Ryan. Thank you for an excellent talk. Ramesh, one of the questions here is, if you don't always use a nasal flap, how do you close the postoperative deficit? That's come from Razim Agev.
So nasal flap is often used for large tumors, especially when you have large defect. And if you're taking off the tuberculum or planum or even anteriorly, you need a big long flap for that. And if you're not using it, for example, if you're using it, if you're doing the operation for a standard pituitary tumor, the only thing I do is to cover that gap with an artificial substitute. Either you can, if there is no leak, I don't really bother using any dural substitute. I just use a sponge-like material to cover the gap. And then one may use some packing material within the sphenoid sinus, but generally for a standard pituitary tumor, I just use a sponge and that's it, nothing else.
Thank you. And then the next question is about using the Doppler for the carotid. What are your thoughts?
Yeah, so Doppler, as you see, Doppler is a useful instrument when you can actually see the carotid. For example, if you're doing an invasive cavernous sinus tumor, if you're an invasive pituitary tumor invading the cavernous sinus, and you have taken the tumor out, then you know where the carotid is, and you can get the pulsation from it, and then you can use the Doppler to confirm it. But if you want to find out where the carotid is, for example, like a paraclival carotid, if you're going to use the Doppler on the bone, you will not get it. But unless there is a dehiscence, for example, in some patients, you may get a dehiscent bony covering of the paraclinoid carotid, and then you can directly get the Doppler on it. Then you can identify it. But often it is when you drill off the bone and then you have to confirm the vessel, especially when you cannot see it in the cavernous sinus, you can use the Doppler.
We're going to take up more questions. Salman, you're the next speaker, just so you're aware. You'll be coming on shortly. But before that, there's another question here from Manuel from, I probably pronounced this wrongly, Encarnacion. He's from Moscow. And his question is about how you deal with aberrant anatomy, Onodi cells, accessory turbinates.
So I didn't show that slide. The best thing, I think this is why the interaction is so good rather than the slides, because the best I mentioned about learning studying the scans before. For example, if you're operating on a pituitary tumor or any other tumor around the pituitary or craniopharyngioma or any tumor coming from the pituitary gland, you have to try as much as possible to find where the interventricular is deviating to, where the pituitary is deviating to. And that gives you an idea where you're going to expect during the operation. Same as Onodi cells and other anatomical variations. Study the CT as carefully as possible. You can see those variations in your CT. And then, if you have an Onodi cell and exposed optic nerve, then you should be prepared to encounter it. So studying those images carefully, the CT scan and the MRI scan, is the best way to not to have any surprises and to make inadvertent injuries to any of the critical structures.
Okay, Ramesh, thank you very much. Just a reminder to everybody, please type in your questions. We'd like to answer them at the end. I'm sure Pablo is online. He's answering questions. So people have been putting them up. So keep bringing them in. I'm sorry if you're on the YouTube channel and you don't have a way of feeding directly to us. You'll have to contact someone possibly who's on Zoom who can then type in the questions, and we will try and answer all of them. Pablo has been answering some online, and I'm sure you have lots of questions. Good. Now we're going to go next to Salman, who is joining us from Pakistan. We're following on the theme here with endoscopic surgery, and we're going to talk about the endoscopic repair of CSF leaks. Salman, thank you very much for joining us. Salman, we can't hear you at the moment. Are you unmuted?
Let me sort that out.
Great, now we can hear you. Thank you.
Yeah, I'm just trying to get the slides to share. For whatever reason, it doesn't want to at the moment. It says it's sharing, so let me stop and go back again.
Okay, no problem. While you're doing that, we'll take one more question then. So same question that was asked to Pablo was asked to Ramesh Nair as well. Ramesh, what is your view on lumbar drains for your operations? I'm sorry, he's probably logged off. Okay. Salman, if you're ready, we will go ahead with you.
I don't know, can you see my screen?
We can, yes.
But I can't get it to work, go on to the slideshow for whatever reason.
Could you try to press F5, or this is a Mac?
This is a Mac. Okay, let me see. I don't know what's the reason here.
Slideshow?
I go into slideshow, yeah. Let's see. Brilliant.
Perfect.
Can you see this?
Yes.
We can see a white slide.
On screen, yeah.
Okay, let's see if I can. I can't see the arrows that I used to forward the slides. So for whatever reason, they're missing.
We can only see a white slide. So
yeah, that's the background.
Okay.
While Salman is sorting this out, if anybody has any questions for Pablo, who's also clearly still online, please type them in. Pablo will...
I'm taking care of that, yeah.
You can read them out and answer them live while Salman is...
Someone is telling you, use the right and left click on the keyboard.
Sorry, I meant questions about the about the content of
Sanjeeva,
presentations.
Sanjeeva, there is a question for me. If there's time, I would like to answer that.
Sure, there was a question about using lumbar drainage, Ramesh.
Yes. So, so that's a good question. It's been a routine practice for me to use the lumbar drain for most cases of extended endonasal approaches. But again, it's not a mandatory thing. You don't have to use it for all cases. Depending on the amount of intracranial resection you do, you can decide whether to use the lumbar drain or not. And often, many surgeons may avoid using a lumbar drain, but it's been my practice to use lumbar drain because it gives you an additional security in terms of CSF leak. The best thing to avoid CSF leak is to avoid leak in the first 1 or 2 days. If you have that kind of, if you have a kind of an exit valve like a lumbar drain where there is no pressure buildup in the brain, the healing process will go on. And then you don't need to have any long-term lumbar drain at all. But if you get a leak, then if you don't treat it, then it becomes like a conduit, and then you can carry on getting leak. And that's why I prefer to use lumbar drain in most cases.
Thank you very much. I think what we might do is we might just move forward one talk.
Yeah, Sanjay, my thing is stuck. Maybe you can just if you can just get me out of there.
No problem. Kazadi, what we will do is, if you are ready with your talk, then we will move forward.
May I put a short question to Pablo?
Of course.
Sure. There is any advantage to use a neuro monitoring, neurophysiology monitoring during all the approach that you showed?
Well, mainly I'm using that when I'm close to the central aspect of the cingulum, which are the lesions which could be growing close to the corticospinal tract. So in those cases, I always use it. And routinely, we use control, somatosensory evoked potentials control in almost all the cases, but mainly in those ones which are centered on the central cingulate.
Okay, thank you.
Thank you, Giovanni.
Sorry, if you could just get me out of here so that stop my screen share, because I cannot stop my screen share.
Sure. Is Kazadi here? Could you take over if you're on the call?
Yes, I'm here.
Great.
Okay.
So we'll go to your talk. So we're staying along a similar theme. We're now looking at the supraorbital approach, and then that's related to that. Kazadi, thank you very much for joining us, and we're looking forward to your talk.
It's a pleasure. Can you see my slides?
Perfect.
Okay, good. Okay, let me slideshow.
Perfect, Kazadi.
Okay. Thank you very much, everyone. Thank you for inviting me to talk about that. I'm just going to the first slide. Getting there. It was on the first slide, but it moved. But okay. Good, there we are. Okay, thank you very much. I'm going to talk about the supraorbital approach to pituitary tumors. But before that, I'll tell you about the background, why we developed this approach. First of all, it's an approach which was described long ago. In 1,900 years ago, Krauss first demonstrated the supraorbital approach. In the 1913, Frazier advocated the supraorbital ridge resection. And in 1990, Pernesky and colleagues popularized, this concept. And more recently, Jane and Delachaux. Those are things which are well known. In our environment, until 1994, we didn't have much data. Few papers were published about pituitary tumors in Zimbabwe, but also across Africa as well. The reasons were obviously because the CT scan was not just yet popularized in all countries. And also there was an awareness about the pathology and including, of course, the technology and instruments, of course, to perform those operations. Yet we know that 21% of brain tumors were pituitary tumors, and we did this study on a 3-year period. As you can see, the number of patients, 37, 42 patients, case notes were retrieved, and the mean age was 43, and there were 22 females and 15 males. 82% of were blacks. As you know, in Zimbabwe, it's a mixed population. 83% of were blacks, which represent the normal distribution of the population. And the referring doctors were mostly practitioners and ophthalmologists. General symptoms patients presented with were headaches, mostly, then blurred vision, and eventually tiredness. But the reason really why they came to our consultations is because of decreased libido, galactorrhea, secondary amenorrhea, and depression. There was a lot of delays in the diagnosis. Average was about 4 years when we went through the clinical history. And the main clinical findings was when patients were losing the vision, that's where really they came, and that was present in about 85% of the people, and followed by other symptoms. And unfortunately, we had 8% of patients who came when they were already blind. And the tests were not very elaborate. We did only basic tests which were available, PRL, cortisol, and thyroid hormones. The types of tumors, we had productinomas, mostly, followed by non-secreting tumors, and then we had 3 patients with acromegaly. The investigations, as you can see, we had CT scans done in 26 patients and MRI in 31 patients. obviously we can realize that some patients had CT scans and MRI as well. The operations were total debulking in about 23 patients and partial debulking in about 14 patients. The outcome, there was no death. 82% of patients were improved. They had a bit of headache. Some had blurred vision. The headaches has improved, the blurred vision as well, secondary amenorrhea, and loss of libido. Of course, obviously, blind patients never recovered. Morbidity, we had 7% of patients who had diabetes insipidus, and the visual acuity was unchanged in patients who were blind. And we had some CSF leak in 4 patients, and hemorrhagic dextrine and epilepsy in 1 patient. All those sort of small morbidities were sorted out without any problem. Now, the reason why now we choose the technique I'm going to describe to you is that within 15 months, patients with macroadenoma, particularly with supracell extension, there was a recurrence rate of 10% within 15 months. And after 5 years, the recurrence rate was about 18%. So we had to find out what was going on. I remind you that all those patients we operated early on were operated by transtentorial approach. This is, of course, the classification we use, the stage 1 microadenoma. Then, as you know, those are things everybody knows, so that I'm not going to expand on that. And of course, the goal of anterior skull-base surgery is ideally curative surgery, where you should be able to remove a whole tumor. It reduces the brain retraction, and of course, nerve retractions as well. And theoretically, it should help to improve the vision. And we should, of course, respect the olfactory nerves, which will be not touched at all, and it will prevent also CSF leak. Now, there are different approaches, as you know. It is the traditional craniotomy approach, pterional, bifrontal, or transbasal, or orbitozygomatic. There is a keyhole craniotomy approach, which is lateral supraorbital and mini-pterional. We have the endoscopic transnasal approach. We have the endoscopic assisted transcranial approach. And of course, other people are advocating radiosurgery in some cases. As you can see in the pictures, you can use either the picture on the right side of the screen or the picture on the left side of the screen, which is the technique we are using, which is showed on the left side. And now, the primary criticism of minimally invasive is that there is more limited field of view. And people are also scared that the removal will be partial rather than really a complete removal. And you can see here a number of variants into this approach. And we had preferred the approach which is on the left side on your screen. I don't know if you can see my arrow, and we have prepared this approach. This is how we position a patient. As you can see, I don't know if you can see my arrow. You see that the head is hyperextended. You can see this axis is almost looking behind by about 30 degrees. And we slightly turn the head towards the left side, in this case. And as you can see here, there is a marking here of supraorbital nerve. It's very important to locate this structure before you do the opening. Again, this is a positioning where the patient now is ready for the operation. That's when you see on the, if you can't see the arrow, you see that on the upper left of your screen, that's the initial view of the dura once you've done the craniotomy, which is a small craniotomy. I'll show you the measurement. And here you see the dura has been opened on number 2. Number 3, we've started now to drain slowly and gently the CSF. And you can see already down here the visualization of the tumor. And the visualization of the tumor doesn't need necessarily to distract, the brain. The brain can actually fall on its own. This is the reason why those patients are put on hyperextension, so that the brain can fall on the back. You see here the size of the flap, of the bone, which is very, very small. Now, as you can see here, supraorbital craniotomy, you see here there is a retractor, and you can see here the optic nerve, which is white on the right-hand side, and here you can see the tumor. And there is really enough space to remove all the tumor. And this is a patient after the operation that's healed very well. And you can see, you don't have to shave actually, but we did it for various reasons. And otherwise you don't have to shave. If you clean properly, it should be all right. So we did 35 patients with the standard supraorbital craniotomy. 12 were meningiomas, 23 were pituitary macroadenomas. And you can see here that the recurrence was in 3 patients, which was 1.3%. As you remember before, we had a recurrence rate which was 18%. You see here, for example, an example where you see the tumor before on the AP view, lateral view, and you see here the tumor after the operation. Same case here, another case where you see the tumor before the operation and the tumor after the operation. Another case here where you can see we're showing the tumor before the operation and below the study of the patient after the operation. I'm showing you also a tuberculum cellar meningioma, which was removed with exactly the same technique. You see here before the operation and AP view and lateral view, and you see here after the operation. I would like to conclude that this is some simple and affordable technique. It allows large space for microsurgery. Many surgical options consider tumor extension and reconstructions. Frontolateral approach is referable, consider bilateral exposure, possibly to combine with endoscope. But I think with this approach, you can actually operate patients with various tumors, which are actually even expanding on the opposite side, which can be very safe. But we have to remember that you need to have the minimum equipment. It means at least a microscope, which is very important. Micro instruments, surgery instruments, and also it's very important to have some training on micro surgery. Thank you very much. That's the end of my presentation.
Thank you very much. Thank you for an excellent presentation. One of the first questions that's come through has been about the incision, how you make the extent of the incision you make for these craniotomies.
The incision, as I showed you, you see that the labeling I showed you earlier. Let me show you the slide. Yeah, that's why I do the incision. Can you see the arrow?
Yes, we can. Yes.
You see the arrow? Okay, that's fine. Now you see I've designed here the supraorbital nerve. We can make the incision from here up to here, but the skin, you can make a superficial incision on the skin. But when you start to cut the muscles, when you get here, you make like a U opening here before you go there, and you get the flap of muscles and you turn it there, so that the nerve remains intact, because the nerve will be embedded into that flap of muscles you've just, elevated. And then the craniotomy will be done basically here. That's the size of the craniotomy.
Well, you've kept very nicely to time, so we can take another question. But before that, I will ask a question. What's your view on the incision and where the hair follicles are? Do you try and avoid them? Do you go just above them? What do you do in terms of the cosmetic outcomes with the eyebrow?
No, I remain into the cosmetically is very good, because after that, all the hair we grow so that the incision will be completely embedded into that. Cosmetically, it's fantastic. You don't see actually the incision.
The next question is about blind spots in the with this approach. Where do you feel the blind spots are with this approach?
I think the blind spots are particularly if the tumor is too posterior. I showed you the meningioma removed. We could see it very well. So that's as far as we can go, which is quite very good. And the far lateral, if the tumor is actually invading the temporal area, that will be a limitation. But by approaching very well and draining the CSF, it is possible actually to retract gently the temporal lobe and do a lot of work on that area as well.
And the final question, another question come up from Janil Gornani. He's asking about doing aneurysms. Well, the exact question is, what aneurysm can easily be done by this approach for beginners? I don't think you can say any aneurysms are easily done, but anyway, let's answer to this question.
I haven't done any aneurysm from this approach, but I could see very well that if I found an aneurysm on the anterior communicating artery or it will be very easy to remove there. To clip, sorry.
May I answer, Sanjeeva?
Of course. May I answer?
Well, Giovanni, we'll hear from you and then from Ramesh.
Okay. About the aneurysm, all the A1 are easily managed. The anterior communicating artery is a little bit difficult, but I did some of them without any difficulties for that. One criticism to the incision: why you go to play with the supraorbital? That is one of the most painful complication for this gentleman. I always stay a little bit lateral, and I don't go where the supraorbital is present.
Well, we never had any complications, and these patients were very satisfied. They didn't have any pain at all. It's very important to make sure that the retraction is not excessive. And when we follow those rules, we didn't have any problem. Patients were very, very, very good. Of course, we filtrate the skin with local anesthesia before we do this incision. And we never had any problem.
We're going to hear from Ramesh now, but I'm just going to make a comment. Ramesh and I, Giovanni, are very experienced surgeons. If you're going to approach any aneurysm through any approach, you must make sure you have proximal control, adequate exposure, and you have to tailor it to your skill level. And yes, you will see today and tomorrow some very, very skilled surgeons and what they do. But you must, of course, be very careful and tailor it to your skill level and do this carefully. Okay, Ramesh, let's hear from you.
Thanks, Sanjeeva. I think you were absolutely right in saying that you can't really say it's an easy aneurysm in any case. Sometimes even the easy-looking aneurysm can be the deadly ones. I hear about this PCOM aneurysms all the time. Either it is dead easy or easily dead, the patient. So that's how these aneurysms are, especially the acute ones. In terms of the supraorbital approach, it's a routine practice, at least for some surgeons, to do a supraorbital approach for most of the aneurysms. So it can be done, and I have done it, and it can be done for MC aneurysm, it can be done for AC aneurysm, as well as in internal carotid artery aneurysms. But as you can remember, after you expose the supraorbital through the approach, the view you get is not very dissimilar to the what you get with the TNL approach. You don't really have to expose too much of a temporal lobe. You're seeing the Sylvian fissure at the back of your supraorbital approach, and then you can dissect the Sylvian fissure. You can see the bifurcation, and you can follow the angioseptal artery to the ACOM. So it is possible to do it.
Good. Giovanni, anything further to add before we move on to our next speaker?
The aneurysm question is not for beginners.
Yes.
This approach is has to be not done by the beginners. You have to know very well the anatomy, and for aneurysm for beginner, okay, do the SAMI approach is much better.
Yeah, this is the reason why I emphasize that we developed this technique for supracellular tumors and the supracellular lesions. It's a fantastic approach for those lesions. Very simple.
Absolutely.
One short comment, Sanjeeva.
Yes.
Imad, yeah.
Oh, Imad, yes, come in. Yes, of course.
For the aneurysm, as Professor Boji mentioned, is not for beginners and not for ruptured one. For the unruptured, some people they have attempted, but I think it's overdoing. It's better to do a proper flap to have the proximal control, as you said. Thank you.
Absolutely, I agree. Ike is also commented. I'm sure we'll be, of course, we're going to be hearing from him later. He may show some videos. He's talking about how you can approach the basilar as well. Again, I reiterate, these are very skilled surgeons, and you have to tailor this to your level, but we'll probably see a bit of that later as well. Now, Salman, I hope you're back. Kazadi, thank you very much for a lovely talk.
Thank you very much.
Can we undo the screen share there, please?
Okay, yes, let me do that.
How are you, Kazadi? Good to
Find
hear
yourself.
from you. No, not too bad.
Let me do, okay.
You just go ahead and
stop. Oh, yeah, here we are. Stop share. Here we are. Okay, I've done.
Crossing fingers.
Excellent.
Okay. Can you guys see this?
Thank you very much for joining us.
It's working, Salman. Thank you.
Brilliant. Thank you, guys. It's really my pleasure. Ahmad and Bled and all the gang. I think it's good to have you all here. And it's wonderful to be back among friends virtually, but still it's worth it. This is where we were planning to go this end of May. Actually, we were supposed to be there at this time. This is the Nanga Parbat base camp and K2, which is behind there. So you can see that, this is, you can see the plains of Aptabad there. And this is the base camp when it's coming to the night. And it's from the plains of Aptabad. You can see all the mountains, all the Himalayan and Karakoram mountains region you can see from there. So it's an amazing area. And you all are most welcome. Hopefully we can get you all there. Hopefully next year we're planning. This year we had the plan, but unfortunately COVID stopped us from going there. My topic is very simple. What we have heard from some of my friends is brilliant talks. Ramesh has already talked about the flaps and all that, and majority of that is already covered. But I'm just going to go through a quick, give you a quick overview of CSF rhinorrhea and repair, and why we should be doing more and more of these instead of giving to our ENT colleagues who are our friends, but still I think this should be a domain of neurosurgery. History is way back. Dandy in 1926 repaired this. And in 1981, you're talking about 40 years ago, the success rate was up to 90% at that time with endoscope. So I'm sure we can do better than that after 40 years. So presenting symptoms, we all know this: recurrent meningitis, intracranial abscess, rhinorrhea, could be unilateral, bilateral. It's important where it's coming from, headache, vomiting, and is there a mass that you can see up in the nose? So you need to look at all these things and need to be wary what you're treating. Findings, obviously you could have a clear rhinorrhea, you could have a bony deformity, you have an intranasal mass, or you could have a patient presenting with meningitis itself. How do we diagnose a CSF leak? Clinically, it's a reservoir sign. So it's a non-specific sign and difficult to elicit. And then there's a halo sign that we put it on, we put something, we drop the droplet onto a cloth or a cotton, and then you see a halo and you say, okay, this is a CSF leak. It's again non-specific, again difficult to elicit, and all these are non-specific tests. Laboratory tests, glucose oxidase, there are a lot of false positive and negatives, and there's bacterial contamination can cause problems. Then there's beta-2 transferrin, which is highly specific, and it's long turnaround time. That's the only problem. And it's not available in many countries because of its cost as well. Then there is beta trace protein, which is very simple, but is under research and not yet confirmed. Beta-2 transferrin is produced by neuraminidase activity in the brain, and it's only present in CSF, perilimbs, and aqueous humor. It's done with electrophoresis and mostly used in laboratory tests, and it's about 88% specific. It's not 100% there as well. Imaging, you could do a CT, you could do MR, you can do cisternogram. Obviously, CT for bony demarcation, so you need to see where the hole is, where the thing is coming from. Is it right side or left side? Is the fistula? You can see on the MRI, and can you see the CSF running down all the way into the maxilla? So, all this is important for us to understand and read and observe this beforehand before we do anything. CT scan is essential because it gives you greater bony details. High resolution is required, 2 millimeter or less cuts, and axial with coronal reformation. MRI, it gives excellent idea where the CSF is coming from, in which the leak is there at the moment. Without the leak, it's very difficult. Meningocele, encephaloceles can be seen, and it can identify a thin rim of dura, which can tell you that the leak is coming from exactly this spot. Additional testing, we can have fluorescein testing. We do this routinely in our cases. You can do cysternography, very painful, and the CT cysternography, worst case. I don't know if you guys have ever seen it. They put the patient on a table and turn him upside down. And so you're down with about 70 degrees Trendelenburg, and it's horrible position. And if somebody who's got meningitis or pain, you need to stay there for a long, long, long time. I'm not sure if I'd ever do that. Intrathecal fluorescence is excellent. You use 0.5 to 10%. You need to verify this. If you use this, a nurse and a doctor has to double check the dose that you've calculated. And once it's put in, again, 2 people have to check it because there are serious risks involved. It's off-label, and you can mix it with 10 cc of CSF and slowly inject over 10 to 20 minutes. Why is it important to know? Because it can cause pulmonary edema. Seizures is a big complication that it can cause. It can cause transient numbness, and there have been reported cases of death. Side effects occur with doses of more than 500 milligrams. The usual dose that we give is between 10 and 50 milligrams. So it's important that, when you're calculating the dose, 2 people do that. What about the CT cysternogram? It's excellent. ENT people always do it, but its sensitivity is only about between 48 and 96%. And it's got severe headache, nausea, vomiting, arachnoiditis, all that could be a problem. So it's not something that I would routinely advise. So I never do this. I would use a combination of MRI and CT, and that gives me all the information that I need for these patients. So MR cysternogram, the advantage is that there is no contrast, but again, the way it's done, it's really unacceptable. The sensitivity for MR cysternogram is up to 90%, and that's what we routinely use for all the cases that we do. It identifies the brain parenchyma, and you can see meningoencephalocele just like in this case as well. Classification of CSF rhinorrhoea, obviously 3 important things play a role: etiology, location, and size. And again, your treatment will also depend on these 3 important factors, because success of surgery depends on the etiology and the location of the lesion and the size of the defect. 80% of these leaks result from non-surgical trauma, 16% from surgical, and because of our surgeons, it's rising, and 4% are non-traumatic. Traumatic, obviously anterior skull-based fractures, most common blunt versus penetrating, congenital encephalocele, or now what we do is FES surgery, transsphenoidal surgery, skull-based procedures. All these can cause problems, and we are doing more and more of them, and that's why the incidence is increasing. Tumors invading through the skull base, spontaneous, for example, a pituitary adenoma, prolectinoma that you've given some medicine and shrunk, and there will be a hole and CSF will be coming down from there. This is a patient in which I just want to show you how we just dry things up, make sure, and you can see different things. So this is one patient who's got a problem coming out from the clivus itself. So there are 3 different kinds of fistulas that I'm showing in this. The initial one was coming from cribriform. This was from clivus, and we use fluorescent, and fluorescent does a brilliant trick for us. And for us, a flap is then rotated, And we put a flap onto this once we have done all this. Then we come to traumatic injuries. Rhinorrhoeas, we see this all the time, and it usually presents within 48 hours. It's because of anterior skull base leaks. Just because of it's more common in anterior skull base because the middle and posterior leaks are rare because dura is adherent there. 70 to 90% stop by itself in 7 days. Those who do not close can give rise to meningitis in 30% of the cases. So how do we localize where this leak is coming from? Obviously, nasal endoscopy, difficult cases in acute trauma, it is very, very difficult. High resolution CT could be very sensitive. CT cysternography, as we said, is very useful, but very painful. MRI, very, very useful. Cysternogram is excellent, but obviously requires an LP. Itself, radionucleotide cysternogram are not done anymore. We used to put pledgets in the nose and see where exactly it's coming from. And now with intrathecal fluorescence, it requires an LP. I do it routinely in all my cases, and I'll tell you why later on. Sites of the lesions are important. Is it cribriform plate, ethmoid, frontal, sphenoid, multiple sites? It's important that if you find a site, always look for another site because 5% of the times there may be another site as well. CSF rhinorrhea following accidental trauma, 30% sphenoid, 30% frontal, and 23% cribriform and ethmoid. Iatrogenic, FES, we have already talked about skull-based surgery, craniofacial resections, all these can give rise to problems. And Dan Kelly came up with this grading of CSF leak for pituitaries and cranial-based defects. And basically they said if there was no leak, a weeping leak, you do not need to do anything. Grade 2 and grade 3 flaps or whatever methods you have, whatever you're comfortable with, you use those. Non-traumatic leaks, high pressure in half the time, and 80% result from tumor obstruction. Rest are from benign intracranial hypertension or hydrocephalus. We know that CSF leak, BIH, and MT-SELA, they have the same demographics and same clinical manifestations. So the question is, could this be just overlap of each other? And nowadays, more and more patients we think is because of their obesity, and we send these patients off for treatment by our general surgeons who are able to reduce their weight dramatically and then take away the pressure, and BIH is treated and you don't need to do anything interesting there. Congenital is relatively rare and it's can present as meningoencephalocele that you can see the big meningoencephalocele here, congenital hydrocephalus, congenital skull defect, usually have a large funnel-shaped defect, and they could have normal ICP in these patients. Management obviously could be conservative. That's what you'd start with any of these, open or endoscopic. Obviously, depending on what kind of fracture you have, if you have something like this, I think endoscope is obviously a no-no here. Look at this eye sticking out. So all this is important for us. Basic anatomy, you need to know where the lateral lamella is and where the nerve endings are going from which the CSF can come in as well. Cristogali sometimes can avulse and give rise to it, and all that is important. Open techniques are for when you have got big tumors, big defects. Obviously, open tumors, open technique works very well. Endoscopic technique, most of the CSF fistulas are managed this way. Varying techniques, varying graft materials, depending on your experience and the 3 factors that I talked about earlier. And there's a more than 90% success rate, majority of the time about 95%. So if you look over here, if CSF stream is coming from the medial side, then we know that it's medial to the middle turbinate, your choana there, and you can see leak coming from there. So chances are it's coming from generally from fovea or from the frontal sinus. If the defect is in the cribriform plate, then it is better to remove the middle turbinate and then to have a better exposure. So you're able to take the cribriform plate aggressively and tackle it for big leaks. So I think it's important to understand the pathology, where it's coming from, and you know it beforehand from your CT and MRI as well. Encephalocele repairs, obviously you can see this encephalocele sticking down and you've got a little bit of blood. I'd ignore that. So you just dry that and then you shrink the encephalocele with the help of bipolars. And the idea of shrinking encephalocele is that you don't want to be having hemorrhage going inside if you're being too aggressive. So you need to shrink it until it goes all the way down, then see the bone all along. And in this case, we had a flap prepared, which was put in at the end. Approaches to the anterior cranium, they could be paraseptal, transethmoidal, and transethmoidal, pterygoidal, or sphenoidal. Area, and it's much easier doing it through the middle turbinate or right next to it, depending on if you think it's necessary. Transethmoidal approach is very simple, and I will just show you a transethmoidal approach. So we had leak coming medial to the, you can see the bulla. So if you
the internet is disrupted.
Salman, unfortunately, I think you're interrupting.
Can you hear me now?
You can, yeah, thank you.
Could you see that video, or shall I play that back?
It was interrupted.
We lost it. We lost it.
Okay, so let me go back. Okay, can you see this now?
Yes.
Okay, yes. So ethmoid bulla, basically injecting local anesthesia there, feeling underneath, and then taking with a backbiter the ethmoid, and you can then see the leak itself coming from the roof, and then you rotate the flap. Graft material are varied, and depending on your choice and the location you're in and the facilities you have, you could use mucoperichondrium, you could have cartilage from the middle turbinate itself, conical cartilage. Many people use abdominal fat, mucosa, fascia, combined plates, and different types of flaps. Depending on what you have, obviously, how big a defect is, you're going to decide where exactly it is, you're going to decide what kind of flap you're going to use. The important thing is you always need to have a double or triple flap, or maybe a triple flap if at all possible, and you need to go all the way to the top. So if it's at all possible, extradural, or in some cases, underlay graft can be used to follow that. But I think many layers of graft is essential. Flaps or cartilage or perichondrium could be used on top of it. Multi-layer technique is the key. And for that, you need to have a arachnoid plane reinforced with intradural fibrin glue or a soft inlay graft of any kind. Many people use just fat. Extradurally, you can remove dura by a bioabsorbable, all that can be replaced by a bioabsorbable material. Bone plane can be replaced with the autologous bone graft or turbinate. And Haddad vascular flap works very well, and it has brought the CSF leak in majority of these cases down from 30% to 4%. Reinforcing the reconstruction with the fibrin glue is applied over the bone mucosa after applying frame of Surgicel. And frame of Surgicel, the idea is you've got a frame and the Surgicel goes all around it. And this cavity is filled with fat, and some people would use a balloon to go on top of it. And these are the basic principles that we need to follow. Sometimes I used to use bath plug, and sometimes you do need to use that. So you put in a cotton or whatever material it is underneath the dura, and you've got a suture stuck to it. And just like bath plug, you plug it in, put it inside, and bring the plug all the way back, snug to the hernia there is. And so you have got a hernia like that. So you snug it there, and then you can use all the way up, and then you can use multi-layer closure. So this is another technique which is very good, and fat can be used, fascia can be used, or any kind of material you can use. Then you can have a sinonasal cavity graft on top of it. So you can use bath plug or a repair of some kind in here, a repair underneath, so you can have a dural repair. So many layer closure, it's important for us when we're replacing this. So then you can have an intradural underlay technique in which you can put a graft there. I many times use taco seal, which has got a dura on one side and it's got glue on the other side, and it's excellent and works very well for majority of our cases. So then you can have an epidural underlay technique. So there are many techniques you can do depending on how big the graft is and what kind of space that you've got. Then you've got a turbinate graft, which is successfully applied in many cases. So you can use middle turbinate, lower turbinate, all that can be used. So I'm not going to go into detail of a paper. So they have got a flow chart in which you've got, when you've got clinical suspicion, use beta-2 transferrin if it's available, and clinical assessment, and then observe and majority settle down. In some cases, obviously you do MRI, CT, or CT cysternogram, or you can have a higher resolution CT and then manage accordingly. Anterior skull base defects, obviously depending on how big is the size of the defect. Small defects can be closed with a free graft or a flap. Leaks in cribriform plate can be repaired using 2 to 3 layers. Fibrin glue or sealant is routinely used, and you can use a dissolvable packing. Lateral skull base, you need multi-layer. You've got repair material like autologous, temporal fascia. You can use a mixture of bone, some kind of tissue fibrin glue, and blood. And you can use that. Duragen Integra also works very well here. And you can use different flaps. Obviously, there are disadvantage of a risk of infection in 5% of these cases. So recipient bed has to be prepared by removing the mucosa, widely expose the defect. You may drill the bone around to make it raw so that your graft gets stuck to the bone, and any encephaloceles must be reduced as shown before. Already, this flap idea was shown earlier by Ramesh, and I'm just going to show quickly how, this flap. So we rotate the flap, bring it up, and then we also use the reverse flap at the same time. And you can see now we are trying to get the reverse flap back into our area, and just you bring it out, and then you bring it down all the way into the choana. So this is a case with a huge defect, and this was done through the nose again, although the defect was big. But again, what we did was identified, found all the 4 layers, and the flap was rotated around. And this is a post-op scan a month down the road of that patient. So predictors of success: good preoperative workup. Technically, you're proficient in sinus surgery, so you need to know what you're doing. You need to know your anatomy. You need to have adequate exposure of the defect. And you need to choose the optimum procedure based on location, based on the size of the defect, and if it's a high flow or a low flow problem. And if the pressure is normal or not. Contraindication: you've got somebody who's got intracranial lesions, comminuted fractures, huge defects, and fractures of the posterior wall of the frontal sinus. And even in that case, many people can come frontally through the endoscope extradurally and repair this. In conclusions, it's all teamwork. You've got beta-2 transferrin, imaging to localize the defect, endoscopy successful more than 90%, and patients require close follow-up for resolution of rhinorrhoea. Endoscopic CSF fistula has a high success rate, but both primarily and secondarily. So if you go in secondary, in those cases as well, it's up to 97%, and should be the primary approach of repair for post-traumatic anterior skull base CSF defects. Thank you, guys. Pleasure talking to you.
Thank you very much, Salman, for a very good talk. And thank you for sticking to time. So we have got some time to take a couple of questions. A lot of the questions coming through, I'll read one from Katal Hanan. There's a lot along the same theme. It's about medical therapy and lumbar drainage in IIH and spontaneous CSF leaks. What are your thoughts on that?
Okay, I think obviously you can give medical therapy, but the question is how long. Majority of the patients do run into trouble with medical therapy for long term. I've seen patients being on medical therapy for 6 months or so. The question is, will you find enough time to be able to correct their problem, which is their visual problems, etc. So I think all that is very important to remember. Lumbar drain, we only use when we are 100% sure that we need it. I use it if the pressure is high. I use it very, very rarely when I failed first time. I use it in big defects, but generally I don't use it. The problems is the nursing care of lumbar drain is very important. How much you're draining every hour, clocking of lumbar drain output is important. And you've seen patients with pneumocranium who run into trouble if lumbar drain is excessively used. I also wanted to point out that with high pressure leaks, what we do is the idea of doing a lumbar puncture and putting in fluorescent is that we look at the pressure at that time. If the pressure is high, I would do a lumboperitoneal shunt first, and then I would fix the leak. And with that, our failure rate has really disappeared. The reason all these patients were failing were because they were high pressure leaks, all obese ladies in their 40s. So I think it's important that you remember that as well.
Well, interesting. There's been a question on what do you do in flap failure? If you do have one, what do you do?
Yeah, I think, obviously with flap failure, there are multiple things that we can do. It depends on what kind of failure it is. As I said to you, the magic thing that has come recently, I have no interest in that, but it's a thing called Tacosil, which has a dura on one side and which has glue on the other. And using that primarily from inside with the flap, we have reduced the problems to less than 1% in the last 2 years of our patients. And we are just writing that up. And once, we're able to show that quite clearly that we're able to do that. So our flap success rate is pretty good. Our ENT guys do not do this. I do it myself with one of our colleague who trained with ENT, and he's pretty good with these flaps, and he's able to extend. What we have done is in the 2 flaps that we had failed, we used middle turbinate and we extended that flap, and we used Tacosil underneath, and we redid the whole thing again, and both of them, and with a lumbar drain, both of them did not give us any trouble afterwards.
Okay, so that's for Sergey who asked the question. I hope that answers it. Is a more extended flap, adjuncts like Tacosil, which we also use, lumbar drainage can all be considered. Well, thank you very much, Salman. And I'm going to now ask if we can get our next speaker, staying along the same vein of talks, talking about surgical approaches to craniopharyngiomas. Ekkehard, could you please come on, and thank you very much for joining us, and we're looking forward to your talk.
Hello all, thank you very much for having me. It's a pleasure to be with you guys. I today want to give a talk on the changing role of surgery and radiation in the management of craniopharyngiomas. And instead of focusing on one particular approach and see what all the things are you can do with it, I want to illustrate that you need actually different tools for one particular tumor type at hand, despite the tumor rather being in the same location. So I want to help people in their early stages of career to make good decisions about what to do and what to pick. Let's hope that this works. Can you see my screen? All right. So I have nothing to disclose. Craniopharyngiomas remain a major therapeutic challenge, even to the most experienced of neurosurgeons. But why is that the case? So we know that.
You want to go to a full screen view?
Yes. So craniopharyngiomas remain a major challenge to even the most experienced neurosurgeon. The question is why? Well, we know that most patients will survive the disease as well as our attempts to treat them for a long time. But we have difficulties in predicting which patients remain virtually symptom-free for decades without any treatment, which ones may be severely debilitated, and which ones can be safely cured with surgery alone. And because morbidity rates for the visual loss and hypothalamic dysfunction remain high, the management has a long time been controversial. So here, a typical clinical vignette. This 42-year-old French teacher came to me from an outside hospital and presented initially with memory problems and some increased thirst. Her history of present illness showed some double vision with minor car accidents. She was more forgetful for a few months, had some increased thirst and urination, and was somewhat fatigued. Past medical history showed bipolar disorder and ADHD and a polycystic ovarian syndrome and some psychotropic home medications, but family history and social history was rather unremarkable. At the outside hospital, she was worked up after a minor car accident in the parking lot with the question of, is she confused, a bit changed in her mentation? And by report, her ER exam was normal and she had also normal labs. However, in the United States, when you have a car accident, most people get a CAT scan and imaging revealed a tumor. This is the initial picture from the outside hospital that we can look through the internet at. So this showed a large supracellular mass of about 4 by 3 centimeters with some cystic and some solid component. Here you see the cystic part and the solid in it. There was no evidence of hydrocephalus and no calcification. So what's the differential diagnosis here? And you immediately think about, could this be a pituitary macroadenoma, a craniopharyngioma, or a Radke's cleft cyst, which are all the same ballpark, or maybe a metastasis, because that can mimic anything. And then there are rare other tumors like a colloid cyst and so on that can also show up in this location. So we requested an MRI scan, and the initial MRI scan was done with and without contrast. And you see in the T1 pre-contrast, T2, the cystic component with the solid part in it, which is vividly contrast enhancing. It sits at the floor of the third ventricle, and on the gradient echo scans, there's no hemorrhagic component. So that makes you think about craniopharyngioma. But what should not make us think about craniopharyngioma in this setting? Well, the MRI scan shows a supra and paracellular tumor with a solid and cystic component. In CAT scans, you see calcifications in more than 50% of cases, and that is more so in the pediatric population. And clinically, patients often present with long-standing hypopituitaries and occasionally diabetes insipidus. Craniopharyngiomas are benign disease, but rare disease. It's only about 2% of all brain tumors in a mixed population with an incidence of about 1 in a million, which is equivalent to 350 new cases per year in the United States, which also tells you that none of us see a lot of this, which tells you there's a lack of experience in all centers. There's a bimodal distribution, about 40% in the pediatric age group and 60% in adults, with males and females equally affected. The pathology is interesting because you usually see a well-circumscribed lesion with a dense fibrovascular stroma interrupted by well-differentiated squamous cell epithelium that forms almost skin displaced in the middle of the brain. This is how it looks on the higher magnification. You see a nice basal cell layer and then progressive differentiation into keratinized cells. So this is a very typical appearance. Now, cytokeratin expression differentiates the main culprits of our differential diagnosis. Craniopharyngioma, Radke's cleft cyst, and pituitary pars intermedia can be differentiated by craniopharyngioma being negative for cytokine cocktail 8 and 20. Here you see a picture where the stains on CK8 are negative in the craniopharyngioma population, and in CK20, where this is positive for Radke's cleft cyst and positive scattered for pituitary pars intermedia. Now there are two subtypes. One is the adamantinomatous subtype, which is the larger number, usually arising from teeth rests and usually in children. This is a rather poorly circumscribed type of tumor and contrasts heavily with the papillary type of craniopharyngioma. That is a smaller group of them, usually occurring from mucosal rests, occurring in adults in a well-circumscribed tumor, as you could see in our sample. The origin of craniopharyngiomas has a classic theory that these arise as embryonic malformations from Radke's cleft pouch. And modern theory has shown that in mouse models, the adamantinomatous, the pediatric version, can arise due to paracrine activities of beta-catenin mutated cells inducing tumor stem cells, whereas the adult version of craniopharyngioma arise via metaplastic transformation. That's why they are more differentiated. Now, there are a couple of classic clinical issues in these patients. Typical presentations are a combination of visual, neurological, and cognitive compromise, but we see a lot of pituitarism, hypopituitarism in 90% of patients, hypothalamic disorders with obesity more than 50%, diabetes insipidus in 80%, and thermoregulatory and heart disease, as well as sleep apnea. There's an increased cardiovascular risk with women more affected, causing arrhythmias, and likely this is from a combination of hypogonadism and exposure to sex hormones. There also is reduced bone health, all translating in decreased quality of life. Now, our patient was transferred from the outside hospital with the label of tumor, and again on arrival, the ER attending the neurosurgery team and even the endocrinologist said she has a normal exam. But if you look at this picture, this is a large tumor sitting in a delicate spot, so it's unlikely to be truly asymptomatic. So don't be shy in calling in the ophthalmologist to say, I need an examination here in the ER, and you repeat the exam and admission labs. So here the urine spirometry was 1020, which is within the range of normal prolactin levels, no stalk effect, normal thyroid function tests, normal sex hormones, and no IGF-1. elevation. And as predicted, the formal ophthalmological examination showed a red desaturation on the right eye. And there's a good app that you can download on your iPad to do so at the bedside. There was also a rapid afferent pupillary defect, relative afferent pupillary defect, which you can elicit with a swinging light test at the bedside. Then we did a formal visual field test, and the Humphrey visual field test showed clear decreased sensitivity in both inferior temporal quadrants, which argues in favor of a chiasma compression. So that is consistent with imaging. In synopsis, we have a symptomatic patient with a cellular lesion that is endocrine stable, but had visual field compromise. So what should we do next? Well, this is not an asymptomatic patient, so wait and observe is not an option. Here we can go for surgical resection. We could do a biopsy and cyst aspiration or do primary radiation therapy, but that is no longer recommended. So I want to take you through this thinking. So there are controversies in surgery right from the beginning. Even Cushing called the craniopharyngioma the most forbidding of the intracranial tumors, and he had massive complications with this disease, largely because at that time, without imaging, they saw late-stage disease. But this didn't change over 80 years. Even Rutger, who was the chief editor of JNS, said that there's perhaps no other primary brain tumor that evokes more passion, emotion, and as a result, controversy than the craniopharyngioma. And that was just like a few years ago. So for more than 80 years, the question remained, what is the right surgical approach to deal with this disease? Aggressive resection or rather conservative management? Well, I can tell you from experience, resection is difficult, both because of the anatomy as well as because of the pathology. And Ramesh has talked about this. These are very sticky tumors that have sort of an unusual texture to it, and they seem to be almost like glue to the surrounding tissue. Also, the paracellar region is a delicate area. It's right adjacent to the optic pathways. It's next to the pituitary, which is affected. The hypothalamus, the circulus vessels, and the mammillary bodies can all be involved, which may influence, as we said, vision, hormones, mental status, as well as a number of other systems. As you can see from a cross-section, we can immediately think about open surgical approaches coming in from the front versus endonasal transsphenoidal approaches. Now, what are the best surgical options? When you go to the literature for open craniotomy, there's a plethora of options available, subfrontal, terional, frontolateral, everything is out there in the market, which tells you nobody has a good answer to this problem. The second thing you can learn here is that transnasal approaches are also available, which can be done microscopic transsphenoidally or entirely endoscopically, but you may need extended exposure and you may have to mobilize your pituitary. So I think approaches can and should be chosen based on the tumor location in relation to the pituitary stalk. And I really encourage you all to study your pre-surgical images very carefully. All my patients get a high resolution MRI scan in 3 planes, and get a DTI, and should get a CTA. And then we decide the tumors are either pre-infundibular, transinfundibular, or retroinfundibular, as seen in this color scheme. This was recently by Kassam published and retyped. So in the literature, you now find 4 types of tumor. Type 1 corresponds to the pre-infundibular tumor, where the pituitary stalk is pushed backwards and the chiasm is elevated. Type 3 is post-infundibular, where the pituitary stalk is pushed forward. Type 2 is inside the pituitary stalk, and type 4 is largely inside the ventricle. The next thing you really need to study is where's the chiasm? Is it directly in relation to the pituitary? Is the chiasm posterior, or is the chiasm anterior? And in a prefixed chiasm, you have very short optic nerves to mobilize. So here I just want to give the beginner 2 ideas. If you think about doing this openly, use an approach you are familiar with. And terional approaches are exquisite because you have short working distances. It's very familiar to you from lots of other surgeries. You may have some difficulties with short optic nerves in a prefixed chiasm. You may occasionally have obstructive view in the optical carotid triangle from perforating arteries, but you can open up the lamina terminalis and look backwards. Transsphenoidal approaches are very nice because you come in at the axis of the tumor and chiasm, and you have excellent visibility under the optic nerve and chiasm, but you can only use it if everything else is elevated above, unless you are really experienced. What are the risks of surgery? Well, the risk depends on anatomy and experience, and it differs a lot in the native setting first operation versus recurrent disease pre or post radiation. I want to point out especially iatrogenic infarction is a major problem, as well as hemorrhage, hormonal disturbances, visual compromise, fluid leaks, all to be named. Cranial nerve palsies and anosmia has been described a lot, as well as seizures. But in my eyes, one of the biggest problems remains the high rate of incomplete resections. So what has helped in the past? Well, there are basically two schools of thought. The one comes out of Children's Hospital Boston that says, hey, gross total resection is the best for all patients. And then you save your radiation therapy for salvage, because recurrence seems to be pretty inevitable in this tumor, and radiation causes long-term problems, so you should delay radiation. The second school of thought comes from Washington. Subtotal resection is probably better, and the cyst decompression achieves a lot, but then you treat the tumor with radiation, and their argument is lower morbidity and higher quality of life. So just give you a summary slide right here before we go into details. The goal obviously is maximum tumor control at minimal morbidity, and in the community, results should achieve overall survival at 5 years greater than 90%, at 20 years 60%. That means these patients are like a walking business card for you. If you do a great job, you will be praised. If you screw this one up for 20 years, they will tell, don't go to this hospital, don't be treated by this physician. So you want to be careful and do this well. Most patients present with significant endocrine function before and after, and one problem that is described in literature throughout is a recurrence rate of about 1/3 within 3 years from index surgery. So why does this happen? Nobody knows. Maybe we stimulate the tumor as we operate on it because it's not related to the mitotic index. The most relevant variables to make decisions are, what is the tumor configuration? What is the patient's age and comorbidities? And what is your own experience? And what does your center deal with well? So for open choices, you have a whole plethora of options. And there's an excellent chapter in Apuza's book from '93 summarizing all of this. And most of them focus around the frontolateral approach. But you can also go interhemispheric, and you can go OZ or transventricular. So I want to show you a good open series everybody should read about. Falbush summarized an excellent series with fantastic follow-up in the 90s. They did 168 of these tumors with a mean follow-up greater than 5 years. And most of these patients were operated in an open way. Patients presented the typical way with largely visual dysfunction, more so in adults. And you can see that most of their patients undergoing transsphenoidal surgery had smaller tumors, whereas the tumors that were operated transcranially were largely larger tumors. What did they discover? In their 94 patients that were operated through an open approach, they only achieved about 50% of gross total resection in the hands of an excellent surgical department with good imaging capabilities. So that tells you this is difficult disease. Mortality was approximately 1% at the first operation, but 10% at recurrence. And the extent of resection was clearly related to size of the tumor, with gross total resection only being achieved in small tumors, 0% for tumors greater than 4 centimeters, which is stunning in someone who is experienced with this disease. What were predictors for subtotal resection? Especially invasion of the third ventricle, calcifications, and to be very adherent to the surrounding vessels, as Ramesh has pointed out. Now, a few years later, Falbush moved to Sami's hospital in Hanover and followed up with a separate paper on only large tumors greater than 4 centimeters, again presenting with visual disturbance and hormonal dysregulation. The interesting point about this paper in JNS is that all patients had pre-surgical MRI with DTI. All of them were operated with intraoperative MRI guidance through the same approach, frontolateral, with opening of the lamina terminalis. What did they find? They only described the immediate outcome. Even large tumors, you can achieve about a 2/3 gross total resection rate, and you achieve still visual improvement in about 1/3 of patients, but at the expense of 50% additional endocrine deficits. How does this compare to modern endoscopic series? And this is not a bad series from Louisville, Kentucky in 2013, where they looked at 64 patients done in the MRI era. 47 of them were primary tumors. And here again, gross total or near total resection rate was approximately 2/3. So not significantly better than the open operation, no matter what they say. What is the outcome? Well, the first problem is that the mean outcome in most endoscopic series is relatively short, but they could show that endocrine status was affected 2/3 prior to surgery, and in another 50% of patients, post-operative DI occurred. And even when patients had no pre-surgical deficit, 50% of the patients showed a new onset post-operative DI. Vision improved in about 2/3 of patients, and again, 1/3 of patients had a clear recurrence within the observation period of 3 years. So that makes you equivalent between the two techniques available. In summary, craniopharyngiomas are suitable for endoscopic surgery, but should have clear features for this approach. They should be largely median, intracellular, largely subchiasmatic. It's better to do this on small to medium-sized lesions and not so many paracellular components. That makes it a lot easier. Now, then came an interesting paper in 2012 out of Miami. Komotar reviewed the world literature at this point and claimed a meta-analysis, and he looked at 3,500 patients and compared all comers of open surgeries versus transphrenoidal versus endoscopic. And in their abstract, they make a very bold statement. They claim they solved this problem. The gross total resection rate in endoscopy was higher than in open. Visual improvement was better in endoscopy than in open. Seizures were less in endoscopy than in open. And only CSF leak was a major problem at that time in the endoscopic literature, not so much in the open. So this looks pretty fantastic at a first glance. But I knew the literature, and I also knew actually this disease. I had this done quite a bit, and I thought like something is wrong with this paper. I need to understand how they come up with this. So I pulled all 88 studies and looked at them in detail. And then you realize out of the 3,500 patients they analyzed, 90% of them were operated on through an open approach, and they lumped together all types, whereas only 5% of patients were operated on endoscopically. The open approaches had a mean follow-up of 5 years. The endoscopic approaches had a mean follow-up of 2 years. So the first problem is that your mean time to follow-up in endoscopy was not even the time to recurrence, which biases your results to looking too good. In addition, there was a selection bias because in most series, patients treated with open surgery had larger tumors than the transphrenoidal group. And that really tells you there's a completely different thinking process of how you approach disease. So patients treated with transphrenoidal or endoscopy had greater rates of visual compromise earlier because a smaller tumor in the cella expanding a little bit presses on the optic nerve much earlier. And because it's smaller, it's much easier to get more of it out. So if you read this really carefully, I think the conclusions were not defendable. There's no clear advantage of any approach, except maybe that vision is noticeably better with endoscopic surgery if the tumor suits it. So I think you need all tools in the toolbox, especially when you start your career and make good decisions. So I want to show you a few cases from my practice. This was a type 1 lesion that came through my pituitary conference to me with a preoperative scan showing a contrast-enhancing solid tumor entirely intracellular. And because it's intracellular location type 1, it can be taken out really well transphrenoidally, and I was able to get this out. Here's the optic nerve afterwards, nicely differentiated, and here's the pituitary stalk separated out without complication. This was a type 3 tumor, so post-infundibular. Although it looks intracellular, tiny as well, you see, oops, the pituitary stalk is again located just anterior superior, and there's a septation in the tumor. So I didn't want to do this transphrenoidally because I was worried I would either destroy the pituitary or sacrifice the stalk. And I decided to go in from frontotemporal, do it laterally, open minimal approach. And I was able to chisel this out in a nice way without complications. This is a case similar to our index case where you see a type 2 tumor that is partially cystic, partially solid. The tumor has a densely adherent portion to the pituitary and to the optic chiasm. So we did this open and the tumor was removed because we could separate it from the optic chiasm. If you come in from the right side, you can create a cyst decompression first that gives you huge working space and allows you a better dissection. I want to mention briefly what Cleveland Clinics has championed, which is a minimal invasive approach to all of this. And I tried this in a colleague of mine who came in and said, you know, I've read all the literature. I do not want to have an open operation for craniopharyngioma. I'm scared of the side effects. So with this scan, the patient came in with the cystic and solid tumor. He asked us to do a cyst aspiration with a stereotactic technique, which we did in a biopsy confirming craniopharyngioma. Then we radiated this tumor with stereotactic radiosurgery. The patient went back to work a day later after treatment, continued to work as a physician. When he came back 6 months later, you see on the lower panel, there was a second operation done where we placed a catheter into the tumor cyst, draining the cyst into a Ommaya reservoir. So this patient got away with 2 minimal invasive surgeries, stereotactic radiosurgery, no comorbidity, and could continue to work as a physician, knowing that at 75, he just wanted to achieve 10-year control rates with radiation. So what did we decide on our index patient that I showed you initially? This is a type 4 tumor that is largely supraintraventricular and also in the third ventricle. So I decided to do this openly. I always get pre-surgical CTs, and you can see there's a nice window to get in here. There's no vessel on the top. The lesion is largely at the bottom, and coming in again under the tumor, we were able to do an excellent resection, including half of the cyst wall, but we could not separate out the tumor being attached with the same vessels to the backside of the chiasm. So I decided deliberately to leave a small tumor remnant right there and to treat this afterwards. What is the next step, you may ask? And here you have to know a little bit the literature on radiation. I just want to show you quickly how this works. So we have lots of tools available in the radiation box. You don't need to know all the details here, but you need to know 2 studies, I think, that tell you the story. This is one out of UCSF 2010, systematic meta-analysis, where the group looked at the literature. They pulled 400 studies with at least 5 years of follow-up to look at control rates. And they said, we want to compare surgery alone to patients that had surgery followed by any type of radiation. And then they did a very nice grouping analysis. They grouped the patients with mean age and same tumor sizes and compared gross total resection alone to subtotal resection alone versus subtotal resection and radiation, and also gross total resection. This is what they found. In terms of overall survival, surgery alone is doing a fine job. Patients live for many, many years, 10 years.
1 minute left, sorry.
Yeah, I'm almost done. Subtotal resection is less of an issue. The patients do rather well. If you add in radiation, you get an insignificant difference between the 2 groups. When you do a subtotal resection, patient has earlier failure. So progression-free survival in subtotal resection is significantly less than in gross total resection. But if you add in subtotal resection plus radiation, you negate the statistical significance. So what you can show is that gentle subtotal resection is equally effective, if not better, than gross total resection if followed by radiation. The same group followed up with one more study showing that subtotal resection has a significantly lower rate in diabetes insipidus, which helps you to manage your post-surgical complications. And they also looked at a study that I pulled here showing you when to do the radiation. Radiation should not be done immediately after surgery, but at recurrence, because you defer your morbidity to a later stage and helps you to get the patient longer into better shape. So what type of radiation should we give? Currently, the standard of care is 3D conformal IMRT, which we did in our patient. There are only 2 things you need to watch out for. Enlargement of the tumor cyst can still happen after radiation in 10 to 20%, and about 30% of patients get pituitary dysfunction. So your endocrinologist must follow these patients really, really closely. We did the same thing for our patient. The patient did great for the next 6 months, resumed teaching. At 6 months, she came back exactly with this problem. Routine pickup, the cyst had re-enlarged and showed a significant compression of the third ventricle, although no symptoms. We went in and basically decompressed that cyst. On that day, the endoscope didn't work. Today, I would do this endoscopically. We did, in this case, an open resection of the cyst and did a fenestration of the ventricle to the basilar cisterns. And on the DWI in the right lower corner, you see that there was no stroke associated. So what have we learned from all this? Key to progression-free survival remains to control tumor growth via gentle conservative surgery in combination with radiation, which can be given at salvage. Treatment-related complications really define here the quality of life and overall survival. The 10-year overall survival is above 80% at this point, and that's why this is benign disease. You need to treat it benignly. So we need to think about smart surgery and limited morbidity for quality of life as much as dealing with survival. Thank you very much.
Thank you. Thank you so much, Ek. Sorry to interrupt you because we had a tight schedule. We have many questions for you. Seriously, most of them you already answered. And let me ask you something very, very brief answer. Someone is asking about the app you showed to check the visibility. That's the shortest answer I can choose for you.
I need to Google it. I don't have the link with me right now, but there are multiple apps available for your iPad. You can find this. Okay.
Anyway, you have many questions now in Q&A. So if you don't mind, could you take care of that so we can keep going with the show? Thank you so much, Ek. Great pleasure to have you on board. Thank you for your contribution.
Sure.
So next speaker, it's my real pleasure to introduce him. This is going to be quite different to what we do usually. And he's Ayub Sherian. You probably know him very well. He's a good friend of me, and he's a fantastic surgeon. He's from Kerala, India, and he's working in Vidyanagar, Nepal. So Ayub, is your turn. Thank you.
Starting to share. Can you hear me?
Yeah.
Yes, we can.
Okay, it's an honor and a pleasure to be here, and it's really good to see all these guys. We missed lecturing together. More than that, we missed the company. But now that we're back together, let me show you some more crazy cases. So first we start off with some dissection, anterolateral skull base. So we are starting with the dissection now. So we are showing, this is the frontal lobe, that is the temporal lobe, this is the orbitomeningeal band, that is the orbit, and here we are dissecting the temporal lobe away from the cavernous sinus. So when Pablo was talking about medial temporal lesions, we could do this and then open the sylvian, we will be right on the medial temporal lesions. So I am literally taking the medial temporal lobe away from the cavernous sinus here, extradurally. Proceeding on, so the cavernous sinus is being uncovered. You can see the superior orbital fissure there, anterior to that, and the orbitomeningeal band is there. I'm cutting the orbitomeningeal band there. See this carefully so that when we do the same thing in the surgery, you should not miss the same thing. So this is how we uncover the anterior clinoid. Once we do this, the anterior clinoid is clearly uncovered. This is a very, very important step. So we do this. There is no need to drill the anterior clinoid as if you are in a hole or something. So you drill this, you take this clinoid, you take this this orbitomeningeal band and just dissect this part, and you see the whole anterior clinoid so beautifully. So we are ready to take off the clinoid now. We uncover the clinoid. So this is the fourth nerve, and the third nerve is here. The fourth nerve overtakes the third nerve. It comes above the third nerve, the superior orbital fissure. So we have to cut parallel to both the nerves. I usually use a diamond knife in my cases, but here we are using a blade. Now you can see we are removing the clinoid process, and that is there you can see the carotid, the extradural C3 carotid, and that is where the optic nerve will come. So we're going to remove the optic roof also, and the optic strut is going to come here. So you can see the outline of the optic nerve, and the strut is being removed here. That is the optic nerve, this is the carotid, and that is the strut. You must remember that. So the endoscopic view, what you saw, this is the optic, this is the carotid, and this is the strut. So you can, I am unroofing the optic nerve also. And after this, I am back to the dissection that we started. So you have V1 there, that is a superior orbital fissure. That is a V2 there, that is a V3. That is a Meckel's cave. That is the fourth nerve. So between the fourth nerve and the V1, you have the Parkinson's triangle there. So if I open the Parkinson's triangle, you're going to see the paraclinoid carotid and the sixth nerve medial to V1. So I'm going to open the Parkinson's triangle. That is at high zoom. That is a vertical paraclinoid carotid. Sorry, paraclival carotid. That is a C5 paraclival carotid. That is V1. That is the fourth nerve. And we are going towards the Dorelow's canal there. This is the sphenopetroclival meningioma. It's very useful to do this. And this is the sixth nerve. You can see the sixth nerve there. Usually you don't hook that out, but that is the sixth nerve, medial to the V1. As we dissect a little bit more, before you can see that the sixth nerve goes medially and into the Dorelow's canal. This is the vertical segment of the carotid. Paraclival. And then now we are going into the posterior fossa. So that is V3. You're identifying GSP, and that's a Kawase's rhomboid. In the Kawase's rhomboid, you have to identify first laterally the carotid. That's what we are doing right now. So you can see that this is where the carotid will come. That is the carotid. That is the petrous carotid. So we saw the C5 carotid, that is a paraclival carotid, and this is the C6 carotid. So that is the petrous carotid. So once you identify the petrous carotid, you can lateralize it and then take off this entire bone except the cochlea here. You don't want to drill the cochlea away, but you can drill it even posterior to the meatus. Okay, you get a large petrosectomy. And so we are doing that now. You can see the IAM, dehiscence of the IAM there, internal acoustic meatus there. So you're taking off the entire petrous bone there. You can see the entire carotid is unroofed. You can go all the way up to this and get this. Once we do that, so this is the C5 carotid. We have opened the dura over the Meckel's cave. The retrogazerian fifth nerve has been freed. So that is a retrogazerian fifth nerve. So you can see V3, V2, V1. This is the fifth, this is the fourth, this is the fifth C5 segment paraclival carotid. This is the fourth nerve going there. This is the clinoid triangle, that is the optic nerve. This is the fifth nerve. That is a pons lateral to the fifth nerve. And then now we go posterior, you will reach the IAM also. I have not cut the 10 here, so I'm releasing the fifth nerve dura here. Exactly what we do for petroclival meningiomas usually. And now you can see the third nerve, the second nerve, the fifth nerve, the lateral aspect of the pons completely. You can see below the third nerve, you can see the duplicated superior cerebellar arteries, and that is the seventh nerve. So that is the fifth nerve, that is the seventh nerve. We've opened the IAM and the loop of Ika, and you can see the 7th-8 complex, that is the anterior nerve is the seventh nerve. So you can see right from second nerve to third nerve to fifth nerve to 7th-8. This is exactly your petroclival corridor, sphenopetroclival corridor, second nerve, third nerve, your fifth nerve, 7th-8 complex. So everything right from the panoramic view we have seen now. So let us go into the next video. So the next video is the same approach we are using to do a basilar tip aneurysm. So here, as we showed you, we have taken the temporal lobe off, and I'm drilling off the clinoid process there. That is a clinoid process there. Drilling off the clinoid process. Once I drill off, I have already mobilized the temporal lobe pretemporally. Now that is the optic nerve, that is the carotid, that is the third nerve. The PCOM is there, this is a ruptured basilar, that's the third nerve there. Opening the sylvian, proximal sylvian, you don't need to open the whole sylvian here. So you open the membrane of Lilliquist, and this is the opticocarotid window. So you are opening the membrane of Lilliquist. This is a ruptured basilar. So it is rather simple if you get the third nerve on the opposite side. These days I don't need to see, you can see the white structure there, that's the third nerve. So if you get the third nerve, you know that this is P1, that is P1, okay? Always P1s are above the third nerve, okay? So you see the basilar, you see P1, that P1, that P1, and that is the aneurysm, posteriorly directed aneurysm. Okay, so I'm putting a patty and I'm dissecting around there. Now I have to dissect between. This is one of the difficult aneurysms because this is a posteriorly directed aneurysm, and this aneurysm I have to dissect from P1 away. So I'm dissecting away from the P1. You have to be very, very careful there because you have no proximal control. I don't like putting in a clip and then dissecting in the basilar. I have had some bad experiences, so aneurysm clipping goes well, but then you have thalamic infarcts. This is not good. So no proximal control, just under BP of 80 mean, I am dissecting the P1 away from the basilar. And the good thing about it is that this is the base of the aneurysm. It is very, very unlikely to rupture. Okay. So now I have got good space there, and I am putting in a clip. Once I put the clip, I keep on applying and then opening and closing, and then opening and closing. I get space like this, okay? And then I see all the perforators. If I am, after I clip the aneurysm, you can see now P1 there, the contralateral P1, superior cerebellar, and then the aneurysm is occluded. Right, so we go to the next video. This is another paraclinoidal aneurysm. This is a transitional aneurysm. So here we are doing the same approach, everything same approach, using the diamond knife to open. Temporal lobe is being taken away from the cavernous sinus. The true cavernous membrane is preserved, so no bleeding. That is a clinoid. But here there is a problem. The clinoid is just attached to this aneurysm. The clinoid is touching that. This is the cavernous sinus. That's the fourth nerve. So I am dissecting the temporal lobe away from the fourth nerve now, and that is the clinoid process. Okay, under very high zoom. This is cavernous sinus with the fourth nerve. So I am running parallel to the fourth nerve there, and I am opening this part. And here you must understand the aneurysm is directly linked, touching, the ruptured aneurysm is touching the clinoid. So you have to be very careful. So I am drilling off this clinoid now. This part I can drill off very fast, that is the optic roof. When it comes to the aneurysm, I have to be careful. So under very high zoom, That is the optic nerve. And now I'm using 1 millimeter drill. That is the aneurysm. You can see through the dura. This is the optic nerve and this is the aneurysm. You can see through the dura. I am taking it off extradurally completely. All the strut, everything I will take off because I don't want, once I open, it's very easy then. So you can keep on drilling out. This is a 1 millimeter drill. It's like a needle. So you got to be very, very careful with this. Under very high zoom, that's a 2 millimeter suction. That is the optic nerve. This entire thing is the optic nerve. That is the strut. And we're keeping on removing the clinoid. That is the aneurysm. You will see when once I open the dura, you will see just underneath the optic nerve is the aneurysm. So all that I have to take off because I have to cut this dura here. All this dura I have to cut. Then I can outline this aneurysm. So I have taken off the entire clinoid extradurally, including the strut, and then now we are opening. So that is the optic nerve and that is the aneurysm. This was the clinoid that I was drilling away. Here was the clinoid that I was drilling away. This is the aneurysm. So the aneurysm is literally touching the clinoid. So this is a transitional aneurysm. So I am opening all these. First, the cistern is a ruptured aneurysm. So cisterns are open first. Take out the blood. And then now it's very easy. Now I put a hook and I just open parallel to the optic nerve. You see, the distal dural ring will come here. This is the falciform ligament. I can come all the way like this and completely expose the carotid nerve. It's very, very easy. Okay? Once the difficult part is done. Once the difficult part is done, it's very easy. So I just keep on parallel to the aneurysm now, and now I'm cutting the remainder of the distal dural ring. It's attached to the aneurysm, so you have to be very careful. No proximal control till I complete. So almost also ruptured aneurysm. So you can see this is the entire aneurysm. Entire aneurysm now, that is the optic nerve. And I am looking for the carotid now. You can see the aneurysm there, intracavernous carotid you can see there. There will be some bleeding. You can put in some fibrin glue here. When you open the roof of the cavernous sinus, there is some bleeding. You can put some fibrin glue and wait, it will stop. And you can see the intracavernous carotid also, very nice. So now you can see the carotid there. That is the carotid. And you just need to put a clip parallel to this carotid. Okay. So we are going to do this. So parallel to the carotid and parallel to the C3 carotid. The turn, you must know where the turn is. And then you put the clip. And that is it. And then you put in one more clip and you are in control of this aneurysm. So you can see the C3 carotid going down there. There is a little bit of dog ear here, and you can take this. You can see the carotid containing intracavernous carotid there and the intradural carotid there. That is extradural carotid. Okay, and now you are putting in another small clip so that you take the dog ear and you don't compromise the other carotid. Okay, so this is the final clip configuration. Okay, I think I have completed my talk. Any questions or comments? You are welcome.
Thank you. Thank you, Ipe. Can you hear me?
Yes, yes, I can hear you.
I think this is the first time you finish, not on time, but even before. Thank you. So
Keeping on, but then masters like Keki and the rest of the guys are there who will not finish for the entire day. I think I am one of the least malignant guys.
Let me ask you something. There is someone, Janil Gurnani, wants to really ask you, once you become interdural while exposing the clinoid, what should be the direction of drilling during the eggshelling of the clinoid? The direction.
The direction should always towards the clinoid, never away from the clinoid. I think that is funny, and also that is the clear answer. You should know where the clinoid is. If you don't know where the clinoid is a game over here, because the aneurysm, you could see it through the dura. So if you drill towards the aneurysm, it is game over. So you should know where the bone is. In this case, no navigation, nothing. Don't even look at the clinoid, nothing. Look where the bone is. If there is bone, take it. Don't worry whether it is optical roof, orbital roof, whatever, clinoid. So you know the general region. Don't drill on the dura, drill on the bone. Take out all the bone and no eggshelling. I am taking out all the bone. Eggshelling is crazy because eggshelling and then you put in a dissector, and that is when the aneurysm will rupture. So you are painting off all the bone, and you just check with the dissector whether whether there is bone or not. If there is bone, drill it again. If there is no bone, very good. Then you can go intradural, cut the whole dura off, and then your aneurysm is very easy, you see. So the drilling is always where you see the bone. It is like my Sylvian dissection. I don't like, people ask me, how do you do Sylvian dissection? I remove all the arachnoid in the region. So there is only vessels. Then it is very easy. You don't have to worry about proximal to distal, distal to proximal, above the vein, below the vein. All the arachnoid you remove. Just keep cutting all the arachnoid away. Only vessels will remain. It's very easy,
Thank you so much. We are running out of time a little bit, and there are some other questions. If you don't mind, you could have a look at them. And thank you so much. It's my pleasure to introduce next speaker. I can see Henry is in the panel, and I cannot imagine someone better to talk about intraventricular anatomy than the president of the International Federation of Neuroendoscopy. So Henry, thanks so much for joining us. It's your turn.
Yes, thank you for the kind invitation. It's a great pleasure to speak here on an event of the WFNS Anatomy Committee. And I thank Imad especially and Vlad for inviting me. Can you hear me? I have some problems with the internet connection, I guess, or is it okay?
We can hear you properly.
We can hear you.
Right. So I have basic stuff. I was a little bit concerned I missed the topic because I thought it's anatomy and everybody is talking about cases and shows treatment paths and so on. So I have just simple anatomy. Imad, is that okay?
It's okay. There is always next time.
Okay, so I will talk about intraventricular endoscopy. That is very important for everybody who is dealing with endoscopic cases, of course. Sometimes it's very difficult to get orientation when we have pathological conditions, such after inflammation or after bleeding, so on. So this is a ventricular system. Everybody is knowing that the frontal horn, the central part, the occipital horn, and the temporal horn of the lateral ventricles. Then we have the foramen of Monro going to the third ventricle, going through the aqueduct to the fourth ventricle. And all these compartments can be approached with an endoscope, especially if they are dilated. So I just want to show you some endoscopic images taken by these diagnostic scopes. They have 0 degree, 30 degree, and 45 degrees. The diameter is 3.3 millimeters. And we have an HD camera to get the best quality which is currently available. And you see this is an endoscopic view into a craniopharyngioma cyst, and you can really see the erythrocytes going through the blood vessels. Such kind of high resolution you can get with an HD camera, and also the magnification if you have a good endoscope. So still so far, although we have chip-on-the-tip technology available today, the best quality is still with a rod lens endoscope, which is attached to a HD or 4K camera. So first we go to the lateral ventricle. The endoscope is inserted into the lateral ventricle via precoronal borehole, what we use for ETV. And we have a 0-degree scope. And that is the usual anatomy, what you can see. Here you see the fornix, the septal vein, thalamostriate vein has a side branch from the head of the caudate nucleus, so the caudate vein. And here you have the choroidal vein, which is running with the choroid plexus. And this is the foramen of Monro. When we look a little bit to the left, we see the septum pellucidum. Sometimes we have a severe atrophy with holes in the septum and only the vessels remain, typical sign of a chronic intracranial hypertension. And sometimes there is no septum and we have a cyclops ventricle. That means it's just one ventricle without a septum pellucidum, and you see the fornix is running free through the ventricle. And here you see the mesa intermedia. This is called plexus and a very large thalamostriate vein. It's another case where the septum is missing and you see the fornix running here, and this is one foramen and this is the other foramen. Then we use a 30-degree endoscope and we look in an anterior direction, and you see there's no choroid plexus. When you go with an endoscope into the ventricles and you do not see choroid plexus, usually you are in the anterior horn. And here you see the white structure. Here is the corpus callosum, and the gray one is the head of the caudate nucleus, and here again the septal vein. And now we just rotate the endoscope. We don't tilt it, we just rotate it backwards, and you see the choroid plexus. This is the thalamus, and this again is the choroidal vein running with the choroid plexus to the back. With the 45-degree endoscope, if you rotate that, you have even a better radar-like overview. So we look in the anterior direction. You see here the white structures is the corpus callosum, and the gray one is the head of the caudate nucleus. And then we rotate the endoscope 180 degrees backwards. You see the thalamus here, choroid plexus, choroidal vein, and this is the central part of the lateral ventricle, and here the choroid plexus goes to the temporal horn. Of course, with a rigid scope, you cannot follow it. For that, you need a flexible scope. Here's another view to the medial side. You see the septum pellucidum is completely gone. You see the choroid plexus of the contralateral ventricle because of this chronic hydrocephalus. So the foramen of Monro can look very different. This is the usual way. It's pretty good size. You see the fornix running here, septal vein, thalamostriate vein, choroid plexus, and you see the small colloid cyst. In the foramen, this was interesting. We removed this colloid cyst and the ventricles became smaller, although there's not an absolute occlusion. This was very surprising to me because I thought there will be no change. But obviously, the CSF circulation and pulsation was already disturbed by the small cyst. You see there's a small foramen of Monro, and also the venous anatomy is very variable. Sometimes you have no thalamostriate vein, sometimes there's a very big one. You see this is a septal vein, this is a small foraminal vein. Very variable. This is a large foramen of Monro, choroid plexus running here, the fornix running here, thalamostriate vein, choroid plexus, and in the depths is the mesa intermedia, and this is already mammillary bodies visible. That's the floor of the third ventricle. Sometimes there is almost no foramen. This was a patient presenting with biventricular hydrocephalus, and both foramina of Monro were completely obstructed. You see a very atrophic choroid plexus, thalamostriate vein, septal vein. And this is also a case of chronic hydrocephalus. You see the fornix is very thin, running here backwards. This was a case where we did an ETV some years ago. So very variable is the anatomy. Now we come to the third ventricle. Again, 0-degree endoscope. We look to the floor of the third ventricle. What you see very nicely is the mammillary bodies on both sides. Here's the basilar tip shining through the translucent floor in this infundibular recess. Another patient Mammillary bodies, and you see this is very important. These are perforators. The perforators always go from the basilar bifurcation in a posterior direction. So even though this is the thinnest part of the floor, never do an ETV here, because when you inflate the balloon, you might rupture one of these perforators and can have a severe subarachnoid hemorrhage. Perforation should always be in front of the basilar artery, and this is infundibular recess. So another patient, this is an ideal floor, very translucent. You see here, this is a clivus. This is the infundibular recess. This is a chiasm. Mammillary bodies, and what is that? That is a PCOM running very far medially. And here you see the oculomotor nerve signing through the floor. So this is an ideal case, and of course the best location for an ETV would be that space. Sometimes if you have a tumor, the anatomy is distorted. This is the infundibular recess here. And you see here, this is a medulloblastoma completely covering the floor of the third ventricle. Now we look with a 30-degree endoscope in an anterior direction. You see this infundibular recess. This is a chiasm, and this is A1 behind lamina terminalis. When we look back, we turn the endoscope 180 degrees. We look back, you see the aqueduct obstructed by a tectoglioma, and here you see posterior commissure. Now with a 45-degree endoscope, we see even better. You see lamina terminalis very nicely. Lamina terminalis is between the chiasm and the anterior commissure, which is up here. You see A1, and ACOM behind chiasm infundibular recess. And now we look to the left side, and this is the chiasm. Then you see here the contralateral fornix. This is the foramen of Monroe on the contralateral side. And this structure here is the anterior commissure, and this is the ipsilateral fornix. So ipsilateral fornix, anterior commissure, lamina terminalis, chiasm. Again, endoscopic view, anterior direction, fornix, anterior commissure, lamina terminalis, A1, chiasm, infundibular recess, and ETV. This is a view to the posterior part of the third ventricle. You see an entrance into the aqueduct, posterior commissure. This is the pineal recess. You see here, this yellow structure is acervulus cerebri. This is the center of the brain. And here you see the roof of the third ventricle with the coroplexus and habenular commissure running here. So all can be seen very nicely with a 45-degree endoscope. When we look through the third ventriculostomy, we come to the prepontine space. You see this, our ETV. Usually it should be in midline, halfway between mammillary bodies and infundibular recess, just behind the clivus. And when we look in, after ETV, you should see the basilar artery. If there's arachnoid over it, then you are in a subdural space and it's not good. You have to open up the subarachnoid space, and you see all the small perforators coming from the basila. Then we look with 30-degree in the anterior direction. What we see is the clivus, diaphragma celli, basilar artery. Then we look in the posterior direction. You see here the basilar superior cerebellar artery, and here's one P1 and the other P1, and this is a bifurcation of the basilar. So this approach IPE is much better for clipping of an aneurysm than your approach. And when we go deeper down, we can see the clivus here, and you see that is abducens nerve. This is facial nerve, vestibulocochlear nerve, internal auditory canal, and here is the lower cranial nerve group, and this is an ICA. Usually you have not so much space in most cases, but sometimes you have a lot of space in the prepontine area, and you can look at these structures. So we come with a 45-degree endoscope, and we look to the left side. You see the basila here, and you see the duplication of the superior cerebral artery, which is a very frequent finding. Also, when you do microvascular decompression, you frequently see that there's a double vessel. This is the oculomotor nerve, and this is the P1. Again, bifurcation of the basilar, oculomotor nerve, superior cerebellar artery. Then a view anterior direction, you see the thin diaphragma celli and the pituitary gland below the diaphragma. Now we are again in the prepontine area, and we see here is the abducens nerve coming from the brainstem. And here we look down to the inferior, the lower cranial nerve group with the jugular foramen. Now I show you a small video. This is the foramen of Monroe. This is a gray substance, head of the caudate nucleus. And now we just turn the endoscope. You see a thalamus striate vein. This is all thalamus, coral plexus, choroidal vein, and you see here moving the septum pellucidum. We turn it back. And then we can go in with an endoscope into the third ventricle. You see there's a fornix here, ipsilateral chiasm, infundibular recess, lamina terminalis with the A1, and ACOM in front. Mammillary body, so we turn now the endoscope 180 degrees, so we don't tilt it, there's no damage to the brain. Don't think that we are doing sightseeing and damaging the brain, it's just rotation of the endoscope. And you see here's the entrance into the aqueduct, and we rotate it back and remove it. And then we come back with a 45-degree endoscope. You see head of the caudate nucleus, and with 45 really you have a radar-like view. You see the caudate nucleus running here, thalamus striate vein, thalamus here, coral plexus, choroidal vein, septum pellucidum moving. And then we can of course not reach this area here because there is an flexible endoscope required. In Germany, we have the problem that it's not allowed for us to have chip on the tip flexible scopes in the brain because you cannot autoclave them, and the hygiene standards in Germany require that we have sterilization, autoclavable endoscopes when we are going to the brain. That's a pity for us, so we have to use old fiber scopes or rigid scopes. Here again, you see the lamina terminalis. Then we look back 180 degrees to the back, and you see the aqueduct. You see the big one is a posterior commissure, pinal recess, habenular commissure, and entrance into the aqueduct, and this is the roof of the third ventricle. It's another view in a suprasellar arachnoid cyst, and you see so nicely the basilar artery coming here, superior cerebellar artery, and this is a P1 segment. You see all the perforators coming from the basilar area. Very important to preserve them when you clip an aneurysm. You see the pituitary gland at the anterior lobe, posterior lobe. This is a carotid, and you see all the perforators from the PCOM. So it's very variable. On the other side, you will see the PCOM is very small. Sometimes you have a fetal origin and they is very large. But here you see it's a very small PCOM, but still there are important perforators which should be preserved. So the fourth ventricle, it's difficult to reach. Sometimes when the aqueduct is wide open, you can go in. You see this is a rhomboid fossa here. This is the cerebellum hemisphere. This is a vermis, and you see Luschke here, and Magendie. Usually they are occluded. That's why you have an isolated fourth ventricle, and then you can go in with an endoscope. Usually it's very small cavity. This is an old video. You see this an old fibroscope that we used at that time in the isolated fourth ventricle. We go in. See, this is the vermis. And then you simply look for the coral plexus, and when you follow the coral plexus, it guides you to foramen of Luschke. But you see the optical quality is not so good. Here's Magendie, it's completely occluded. This is a rhomboid fossa, and here completely occluded foramen major D in the midline. So we can also come from the back to have another view into the third ventricle. This was after resection of the neurocytoma in the pineal region. And you see, when we look from here, you see the fornix running here. And this is the anterior commissure. This is now a 30-degree endoscope. You see very nicely anterior commissure, lamina terminalis, optic chiasm, infundibular recess. And this was our ETV, which we did before the surgery because he presented with hydrocephalus. So now some questions for you. What is this structure? Participants have to sell something. It's an interactive session.
I'm checking the chat, Henry. I'm checking it.
What?
I am checking the chat.
Can we answer, Henry?
Yes.
Okay, so that is the A1A1.
No.
The basilar tip.
This is basilar tip, mammillary bodies, mammillary bodies. This is P1 basilar tip. What is that?
Infundibular recess.
Exactly. And what is that? This is for the vascular guy.
Big P1 maybe.
It's a
big
wick.
PCOM.
Yeah, this is a PCOM. Comes from the carotid, goes here to the P1. Very big one, but still you can make an ETV in a safe way.
I must say that everyone in the chat is responding properly. So they learned it.
That's good. What is this structure here?
Wow.
Same on this side, it's more easy. What is this?
Is it fornix?
Like the fornix?
Yeah. 3 points. Very good. What is this white structure running from fornix to fornix in this area?
Anterior commissure.
Anterior commissure, right. Sometimes really strange to see if you have this chronic hydrocephalus and just only the main fibers are remaining here, all other structures are destroyed.
Great picture.
Now here, what is this? Now we have these 3 levels. What is this structure?
Fornix.
Fornix.
Anterior commissure.
Anterior commissure.
Chiasm.
Chiasm.
ETV.
ETV. Wow.
Too easy, Henry, too easy.
And last one, we look to the posterior part of the third ventricle. So what is this?
Posterior commissure.
Which one?
Posterior commissure.
Posterior commissure.
Exactly. The big one is posterior commissure. It's just above the aqueduct. What is this?
Pineal recess.
Pineal recess. Yes. Sometimes you see these scent-like structures, which indicates that the pineal gland is not far away. This is
habenular
commissure. This is called suprapineal recess, and you see the coral plexus on the roof of the third ventricle. This is the ideal anatomy. What is this?
Pharmacy.
Yes. What is this?
Massa intermedia.
Is this one?
Massa intermedia.
Exactly. And this one?
Posterior commissure.
Anterior.
This is fornicis. Anterior commissure. Very good. Very good. You passed all exams. Congratulations, my friends. Thank you for your attention.
Send the certificate.
Henry, these guys were supposed to be experts, man.
Yes.
Henry, thank you so much. And
Henry,
I must
let us answer. So
yeah, I must give credit to everyone because everyone was correct in the chat. And we have many questions, Henry, but I chose only one of them. And Alu Sain is asking you if you always use, can you hear me, Henry?
Yes.
He's asking you if you always use 0-degree scope for ETV, and in case not, when do you use different angles? In which cases?
Yeah, these angulated endoscopes are just for inspection. So we look around, we look to the left, to the right, to see the anatomy better. And then for the ETV, of course, we have a working endoscope with a working channel, and this is only 6 degrees. Otherwise, you cannot look properly in the anterior direction. And then I always use a 30-degree endoscope to check the prepontine cistern to make sure that the basilar is exposed, and also want to see, is there any additional membranes? You know, the first layer is the floor, then we have the Lilliquist membrane, but frequently you have multiple membranes further down, and these should be open as well. Otherwise, you have not the pulsatile CSF flow, which is required that your CSF is, that your ETV is successful. But the 30-degree endoscope mainly is for the inspection of the prepontine space.
And we have one more question. How do you manage those patients which have small ventricles?
Oh, the question is it a good indication to make an endoscopic approach? So if I have a tumor and small ventricles, I usually do a transcallosal approach. If I have a patient with slit ventricles and he has problems with a shunt, then we will occlude the shunt, dilate the ventricles a little bit, and then we go in with neuronavigation. Sometimes we take biopsy from tumors in normal sized ventricles, not very narrow, normal size, and with navigation, it's a very safe procedure. But if you have slit ventricles, then I think the endoscope is not the best choice in many cases.
Great. So I must thank you again for taking your time. We knew that you were in the OR today and you were running back home to be with us. So we really thank you. We really appreciate it, Henry. Thank you so much.
I thank you for the invitation to contribute to your committee. Thanks.
Thank you, Henry. So next speaker, we have our chair, Imad Kanan, and he's gonna talk us about the retromastoid approach and variants to the cerebropontine angle tumors.
Okay, do you see my slides?
Yes, we do.
All right.
Yes.
Wonderful. Well, I'd like to thank the attendees that they have been patient to wait until that presentation, but giving something like what Henry giving is fantastic, and I'm sure it's a lot of education material by all the faculties. I'm going to talk a simple talk on retromastoid approach and variants to CP angle. I'm not going to do much on the pre-sigmoid approach, combined Hakura approach, because my colleague, Dr. Sanjeeva, I'd like to give the anterior petrosal and posterior petrosal. So a piece of chronicle history, we have to mention something that Koch and Hellenberger were the first to coin the CP angle as a region. Thomas Arundel did the first successful surgery, but I'd like to jump on Cushing, one of them, oh my God, one of the masters of neurosurgeon. He called that area the bloody angle because the outcome of his procedure was very poor at the time, no microscopy. Dandy modified his suboccipital into unilateral approach and make it more lateral to become the first retromastoid approach in 1934. And of course, Conce and Rand, they were the first who performed the microsurgical total resection using the microscope very early in 1957. Of course, William House, he developed the translabyrinthine, and I leave these things for the DNT. I'm not acquainted with these approaches. The most common pathology we see in the CP angle is the vestibular schwannoma, followed by meningioma and epidermoid. Just a piece of information, all these CP angle tumors represent only 1 to 2% of total intracranial tumors. But you see how much, because of the challenge, it became very attractive for all of us and to focus on this area. These are the different approaches, the retrosigmoid, pre-sigmoid, retrolap, and the pre-sigmoid retrolap combined. I left the two translabyrinthine and transcochlear out because these are for us as a neurosurgeon, they are not hearing saving procedure, and usually we don't like to do them, and we join our ENT colleague to perform such procedure. How you select the approach based on the size of the tumor location. Is there a component going on the porous or along the notch going up? The extent of tumor, the pathology you are dealing with, experience of the surgeon, and the preoperative condition of a patient. I like this graphs because it shows the two common approaches. So of course, the frontoorbital zygomatic can give you access to posterior cavernous sinus, and you can reach even Mickelscape. But the Kawase approach, which is the anterior petrosal, and the retrosigmoid is the posterior approach, is the powerhouse approach, like the Terion approach for the frontolateral area. And Yazerji, a long time ago, he divided the petrosal tumors into three: anterior, middle, and posterior. You can see it on this picture here. And we'd like to divide them by the level, of course, the level above the Mickelscape and between the Mickelscape and the internal acoustic meatus. This is the segment 1, and the level of the internal acoustic meatus is 2, and below the jugular is 3. And from these levels, you can decide what is the ideal approach for you to go. But now, talking about endoscopy, I will give a few statements that using the endoscope as a hybrid with the microscope, it gives you the extended arm along the tentorium to go higher up without having the complex procedure we used to do in the 80s and early 90s, a lot of drilling and time consuming. This is the Kawase approach. This is our friend, Dr. Kawase, looking to his approach. And of course, this has been described, and I'm sure Dr. Sanjeeva will go over this. These the two giants. I said that I was privileged to spend some time with them. Professor Yazerji when he was in Zurich, and Professor Majid Sami in Hanover. Both they have excelled with the posterior fossa approach, and especially the retrosigmoid approach. And both they popularize the procedure that has been done earlier, the sitting position, because they have been trained on the sitting position. Dr. Kurt Sherman, he was the chair in Mainz, and he was doing his cases in sitting position. So this is an evolution that the son take it from the father, and the son give it to his grandees. And I think this is the authoritative approach. That's what I told him. You get trained by somebody who's doing mostly sitting position is very difficult to deviate. I was privileged to learn the sitting position in Germany, and I continue to do that 15 years. But eventually, I have some trouble when I moved to Saudi Arabia by our anesthetist. When I tell them sitting position, they have to take Prozac, and they got so stressed because of the air embolism issues. And I came with this idea that park bench procedure can mimic a sitting position, especially with the new development of new tables. You can flex and fracture these tables, and you can elevate the trunk of that patient. You see, this patient is almost in the semi-sitting position, a sloped position. So whenever I'm dealing with a lesion like this, I'll put her in that position. Well, at the end of the procedure, I flatten the bed, so not pneumocephaly, and I can handle the cerebellum very well by tilting the table forward. I did have arranged for a video, but I thought the time does not allow within 20 minutes to talk about all these things. But this is the position we'd like to do, and this is the type of incision I will say. And of course, now navigation system has facilitated a lot of localization for us, starting by the incision. But for people, in some places, they don't have the navigation. This is still the gold standard. You follow from the protuberance occiput along the zygoma arc. This is the line that is where, in most of the cases, the lateral sinus is. And the astrium is the junction between the lateral sinus and the sigmoid. So when you do your bob hole, you just put it a little bit lower than the astrium, and you make the flap 2 or 3 bob holes. It will be adequate to expose nicely the retrosig approach with the smaller flap that you need. And the mastoid tip is, of course, it highlights almost the base of the posterior fossa. That picture on the other side, this is not the type of incision I'll do. I took it from the web. This is the type of incision I'll do. And specifically, I put that picture up because of the occipital minor nerve. If you see it on the way, don't try to cut it. Just dissect it and move it, because some of the patients after the surgery, they complain of pain and headache from this one. So you try to mobilize it. Don't take the monopole and cut everything on the way. Try to be more anatomist. And the same with the occipital artery, especially if you are dealing with the vascular surgery and aneurysm of the ICA or PICA, and you have to close vessels and you do bypass, leave that vessels like what we do with the superficial temporal artery. Now, this is a small trick I learned from Professor Yazarjil before you open the dura completely. And you see this, he makes a small incision at the base of this opening. This is the cisterna, near the cisterna magna, and I'll just play it a little bit. This is a tense dura when you start. If you open the dura where you have a big mass, that cerebellum might herniate against you. And then it will be strangulated, and it will be very difficult to handle. You have to resect it. So this is a small things I'll do. I'll incise this cisterna magna. Use a scissor, and most recently, and now I just use a needle. I use a needle and let it drain. And usually I leave a small suction at the bottom here above the pad. You see the pulsation of the dura. And then when you have a relaxed dura, you can cut the dura without having the cerebellum pressing against and making that mass effect, because you relieve the CSF, like cystenostomy with our colleague concept, Professor Ive. So then we applied the technique of everybody, central debulking of these tumors. And there are different variants made for this approach. Some people say, look to the facial nerve to start with at the flocculus. Some others say, drill first, so you can identify. In most of the cases I don't have this very tiny small tumor that you follow this concept. Usually this tumor is giant, big, that will cover the whole area. So the first things I will start, I identified the suprameatal area and the tent, so I know where I am. And then I start with central debulking, as you've seen on the video, and then dissect the surrounding by maintaining the arachnoid. So the steps of this is written here. Proper position is very essential. Maintain the arachnoid layer, relieve the CSF, capsule dissection, and I'll use the stimulation probe. There have been a lot of talk that if you use the stimulation probe for dissection and do a lot of stimulation, that the amplitude of the facial nerve will be declined. I never have been doing this for almost 14 years with no problem. We low power dissection, especially when I am near the nerve, so I can do the dissection at the same monitoring, and that dissector is malleable, as a fantastic, like a Rosen dissector. These are some of the cases I did before and after. And this is a giant one. I lift something. There is nothing wrong by leaving a little bit of the vestibular schirm at that size. we have alternative treatment to handle this one. Important, you have decompressed the optic chiasm. And in giant tumor, I will summarize later, the most important factor, remove the bulk and maintain the integrity of the cranial nerves. So don't give a young lady a facial palsies that she has to live with for all her life. And this is the outcome of the facial nerve in general in CP angle tumor surgery. I didn't bombard you with the statistic. I was having several slides from publication by Professor Majid Sami, by Atul Goel, by Misra. There are many good papers on that. They are all coming to the same conclusion eventually when it comes to the sizable one. Of course, Professor Sami's experience, nobody can match it of 5,000 or plus cases, but he was privileged to have a major referral and have these small cases as part. Almost half of his practice were with a small tumor that you can save the facial for sure, and you can even save hearing in some of the cases. So size of the tumor, location, pathology, I'm talking about CP angle, experience of the surgeon and the extent of the resection, and most important, the presence of intraoperative neurophysiologists to monitor the nerves. Some people in the past, they have short temper. They said this elongate the procedure, but on the cost of the quality of outcome. This is a summary of several papers about the smaller tumor. Conservative treatment of small tumor, it become unacceptable in elderly, in patients with a high comorbidity, they cannot tolerate a long procedure, and patient who has serviceable hearing, even with no progression on imaging, in 1-2 years, they will lose the hearing. Even the cases Professor Sami published that he saved the hearing, in 1-2 years, they start declining. I think it has something to do with degeneration or ischemic, chronic ischemic changes. So it's a clinical wisdom and a judgment call, and depends on your experience in saving hearing. So the conclusion, total or near total resection should be the goal in giant. Preservation of hearing is extremely difficult in my hand for a giant tumor. And even on small tumor, if you save it, the gut was on a follow-up in 2 or 3 years. Integrity of the nerve, as I mentioned, of cranial nerves and the brainstem is your priority. For meningioma and the CP angle, we apply the 5D, which is decompression, dissection of the arachnoid, of course, and I sometimes drill the ridge of the petrous bone, like what we do drilling the sphenoid ridge. So the retromastoid approach, it gives you several avenues, but the avenue I like when I have a large tumor more medially located is the suprameatal approach. This approach was described a couple of years ago by my friend Amirati and Majid Sami when he was with him, and they followed the suprameatal approach to access tumor from there and incise the tentorium medially, so you have access to an extension going along the tentorial niche. And of course, it gives you the privilege to go below the facial vestibular nerve complex. This is a case. I'm going to show the video. This is a lady presented with headache. She has this meningioma, very concerned of potential having any facial or trigeminal problem. It reached the tentorium edge, as you see on this image. There is no major compression, but a meningioma and patient have 50s. If I wait on that, there is a potential of progression. I will show the video. I'd like here to give my thanks to my chief resident. He's now with me. He's playing the video. Dr. Ahmed Al-Ahmari. He put some of the question to you or today on the web, and he answered a few of them. This is the meningioma we devascularized, and then we start peeling the arachnoid. That technique used by Majid Sami, even with the acoustic mainly, I like to use it by using 2 forceps to peel the arachnoid. This is important. This arachnoid in meningioma and other disease belong to the brain or to the brainstem. Don't use the bipolar immediately and weld the arachnoid on the meninges, on the capsule. Now you see, we put the endoscope, you have under the tent, and you see the medial part to the tumor, and we see the third nerve, and we see the brainstem and the ICA. Now back to microscope, and I start peeling the arachnoid. Put the microscope, the endoscope again. I alternate between the them. And now I'm taking the tumor capsule and the attachment sharply, because I have nothing to be worried about here. It's along the tentorium and posterior part of the petrous. Use the Kuza to do some debulking after I did the devascularization, so I'm not working on a field filled of blood. Now once I took a good part of it, I start lifting this. I leave some so I have a hold, because this will help me to dissect the arachnoid. This tool I am using is a ball dissector. It's a beautiful tool. I use it in aneurysm surgery and here to hold on this lesion, because if you take the biopsy forceps, it will fragment this tumor for you. And you see now the arachnoid peeling. And you see how it comes over the brainstem. Now, tumor after it can be removed easily. After it was disconnected from its attachment, can be taken in 2 pieces and maintain the arachnoid. You see the trigeminal nerve nicely below, with cover the arachnoid down, and the attachment is coagulated. And then now we will put the endoscope again to see if any residual. So this is the trigeminal. I'm seeing a little bit residual here, and this is the 6th nerve. Live, you see it going into the Dorello canal, and this is the 3rd. This is the 6th again. This is the ICA. And this is the motor part of the trigeminal, and this is the sensory part. So this is after remove of the last piece. And you see, as we went infra-supra, but laterally. And this is the post-operative dissection. See the cerebellum as is not touched. Check back to the presentation. The pre-sigmoid approach, there are many advantages. Once you do this procedure, you have a major exposure from cranial nerve 2 down to 11. The Hakuba approach, the modified, but the entire 3 procedure. You can spend time 6 hours doing the drilling and the 2 or 3 craniotomies, posterior fossa, pre-sigmoid, and the subtemporal area. But one thing I want to stress here, I leave the rest for Dr. Sanjeeva. we'd like to do the mastoid flap when we do the pre-sigmoid approach by using the P1 from pediatric craniotomy without shield and cut the mastoid in a triangular shape and then use the chisel, take the outer layer of that mastoid. So when you finish, you can always refix this one. It's a nice cosmetic and it helps supporting any graft you put for your CSF control. This technique, not my own design. This is made by Fukushima. He taught me this technique and I use it frequently when I do this approach. One thing about bone flap, you see the bob hole. When you take the muscle from the suboccipital area, of course, the teaching, we always say no pipe, no monopolar. For posterior fossa, I use liberal the monopolar needle because you see the emissary, this is the picture of the emissary down. They are flushed with the bone if you take the monopolar and just cut them at the level of the bone and wax, rather than to use the raspa or the respiratorium to pull on this emissary, and they might lacerate deeper the sinus, especially over the sinus or over the mastoid emissary. So that area, I cut it flush at the bone level. The rest, I use only the raspa. For the pre-sigmoid approach, this is an important to select the approach. If you don't have a good Troutman triangle, this is the pre-sigmoid area, adequate for drilling and expose, then you cannot do the procedure. So you have to make judgment, and by looking for your images as well. This is from Dr. Mufti's pictures. And this case was done with the pre-sigmoid approach, and this is post-op resection. You see, as is not touched because it gives you a good exposure. And you see CSF and prepontine sustain is back to normal. And this is another one. And we left something at the back of the dorsum cellae and the cavernous sinus. So it's fine if you leave a little bit of this in a patient who is 60 or 60 plus. But important to understand the venous drainage in that approach. Vein of Lavey is very important, and the venous system, and Dr. Ohata, who worked with Dr. Hakuba, has published a nice paper of retrospective drainage system from the sphenoparietal rather than from the petrosal. So you have to be careful when you are planning to ligate the superior petrosal sinus for the pre-sigmoid approach. This case, it has a component supracellular along the notch. I was trying to do pre-sigmoid. We were a fan of pre-sigmoid. But when I look to the sinus, lateral sinus and sigmoid, see, it's very prominent. And this area, there is no space. So I thought, let me try taking it from below, cutting the tentorium, and use the endoscope. And that's what we did. And you see, this is post-resection, a beautiful picture after the resection. The last tumors I will talk about is the epidermoid. Epidermoid can reach a big size. It's a creeping tumor. I always say it goes from one system to the other, does not respect vessels. It goes around the vessels, around the nerves. But its removal, once you do it, you like it. I call it the chopsticks technique because I use just the dissector and the suction, and it will be, we mobilize most of them. And I want to show another video we did. We're using the endoscope. Let's show this video. See, we are doing a CP angle from the left side, small opening. Just move it forward. Again, this famous ball dissector, I'm using it. important in this procedure to pay attention to the perforator. You see a lot of perforators here. There are few there. They are not a tumor vessels. If you go more precisely, slowly, you will see these are fibers of nerves. And you see how they can, but they are easy to dissect in most of the cases. Sometimes it's very adherent to the brainstem, and then I leave. If it doesn't come easy, I will leave it. These epidermoid person can live 10 years to get their recurrence if they got it. Of course, the problem in CP angle lesion, retromastoid, you have to work between the nerves. But if you have the command of microsurgery, you will be able to do this. You see the small vessels. Now I put the endoscope, and I thought I removed a good portion of this tumor, but you see, there are still tumor next to the brainstem. This is brainstem, and I'm using now the CUSA under vision of the endoscope. And you see the view after a good resection. We still have residual tumor. We are handling slowly, but we are inspecting. The view you get by the endoscope, you cannot get the same by the microscope. It gives you a near vision and a panoramic view. And you can follow any residual lesion that is hiding in the blind corner for the microscope. See, now this is the stimulator I told you about. See, now I'm not stimulating, but I'm using it. But I have fibers on it. I don't know, it looks like a nerve, or fibers of a nerve.
So Imad, we have 1 more minute.
I am almost done. So this is from my view from the endoscope earlier. I know there is a fragment there. So I go with this probe and I try to trace it back. Here it is. Okay, we'll go to the next. So for the epidermoid, as I said, chopsticks, I use endoscope. And this is the home message. Don't be part of a master of disaster, and accept simplicity and appreciate sometimes imperfection. Thank you very much.
Thank you so much, Imad. We have some questions, but there are 2 interesting ones. And Tsotne is asking you about the role of intraoperative neurophysiology. How do you manage that? What do you think about it? How do you perform it?
Yeah, I think we mentioned it. Now, all these cases, we have a neurophysiologist and the technician. The technician learn how to do this part, and they call the physician, because in the early practice, we ask the physician, the neurologist, to be all the time, and this is something they won't accept. But eventually, after teaching the technician, we'll take the cranial nerves. They are involved the 5th and 7th and the 11th, and we do the brainstem motor evoke potential. In the old days, 20 years ago, we don't have the motor evoke potential. We used to do the somatosensory. This will not reflect about the motor dysfunction after the surgery sometimes. The other advantage of the neurophysiology, even your position of the patient to start with, if you have flexed the neck too much in an elderly, they will tell you there is signal changes. If you have a pressure on the plexus while you are putting the hand hanging and there is no support or padding, they will tell you. If the elbow under pressure, they will tell you. So it has a lot of value. And if you want to make your outcome, good outcome, you should not do this procedure without the neurophysiologist.
Thank you so much, Matt. So I think we are on time.
Can I have a little remark?
Please.
Imad, you have perfectly shown in one of your videos the meningioma. The meningioma surface is not smooth but rough. If you have a smooth surface of the meningioma, it means you are in a wrong space, that the meningioma is still covered by the arachnoid. Do you agree?
I think that, no, I don't. I think you've seen the arachnoid dissected.
Right, right. But if you have smooth the surface of the meningioma during resection,
of course, they have, yeah.
You must be looking at the rough surface of the tumor.
Yeah, I get your point. Arachnoid, it gives a smooth surface and shiny surface on the meningioma.
Exactly.
That's why all meningioma, you start by trying to open that layer and identify it and dissect it from the surface of from the meningioma proper, from the caps.
Exactly.
Right.
So we were watching the room, Imad. We were not sure if there was someone with you because we saw 4 hands and only 1 person.
Yeah, I mentioned Dr. Ahmed. He is the chief physician. He was the one who put the video for me.
Yeah. Thank you so much. Thank you so much. So next, last but not least, we have Sanjeeva from Oxford University. And he's going to talk us about the Transpetrous transtentorial approach. And then we will be over and we'll wait for you tomorrow. Sanjeeva, it's your moment.
Thank you very much, Pablo. Can you hear me okay there?
We can.
We hear you, Sally.
Great. And can you see my screen?
Yes, we can.
Perfect. Thank you very much, Imad and Vlad, for the invitation. I think it's been a very good day. I've learned a lot myself from these talks, so it's been excellent. One person we really have to thank, who did a huge amount of hard work here, was Pablo, who fixed a lot of the problems, did a lot of work to make this session. So if you enjoyed this, which I'm sure we all have, Pablo, thank you very much for a lot of hard work to make this happen today. And well done on all of that. I'm going to talk today about the Transpetrous transtentorial approach. And I'm sorry, Imad, I'm not really going to talk about the anterior petrosectomy. It's only going to be mostly the posterior petrosectomy. This is an approach that I think is very helpful. Oh dear, I'm having the same problem as Salman and I can't move forward. Here we go. Okay. This is an approach that I think is incredibly helpful for coming around for lesions in front of the brainstem. And these are just some of the tumors or lesions that we would treat using this approach. So you can see when you have very large and what might be very tough tumors, although equally you could come retrosigmoid, but if you think it's going to be challenging, you could look to use this Transpetrous transtentorial approach. If you think the plane is going to be poor, and it can be in some of this, the pairs involved, you've got cystic changes within the brainstem, or you're seeing a very vascular and very large tumor, or even a tumor here on the far right. We didn't do all of this, but we used it as part of a combined approach. But you can see how, you know, both cavernous sinus, both carotid arteries, the brain, basilar brainstem are all involved by this. This is a very good approach. So these are the types of things you could look to use this approach. So as I said, it's for lesions that are anterolateral to the brainstem. I use it a lot for petroclival, chondrosarcoma, schwannomas. We occasionally, I team up with my vascular colleagues and we go for brainstem or basilar trunk lesions as well. So before we go into the approach itself, I think it's very important to talk about the posterior fossa. And you have to understand that the posterior fossa is a cone like this, and you have to understand which approach gets you where in the posterior fossa. And I know Imad sort of touched on this already. So the first thing you think of course, when you're coming to the top is you're thinking of the Kawase here shown. And usually for me, and I know, you know, depending on how much drilling you do, some people view this differently, but for me, if you're above, if it's a tumor above the IAM and going to the petrous apex, then yes, the Kawase is a very reasonable approach to use. And I really wouldn't use it for anything going lower than the IAM. If the retrosigmoid, of course, is the workhorse approach. For most pathologies, you know, at least once a week, we're probably using the retrosigmoid approach to go into the CP angle and get lesions or tumors in that area. And of course, when you're lower down around the foramen magnum, you're then looking for the far lateral approach. But today, we're going to talk about essentially using the posterior petrosectomy. So coming, you know, through the petrous, cutting the tentorium. And we're really looking for this transpetrous, transtentorial approach that really shifts us around, coming around the front of the brainstem to get to lesions more anterior there. So what are the components of this approach? So usually what you do is you'd have a middle fossa craniotomy. And then as we're going to see, we're going to pick one of the various, we're going to pick one of the various pre-sigmoid approaches, whether you're going to pick a retrolabyrinthine approach, a translabyrinthine or a transotic approach, and then you're going to cut the tentorium. And that's what's going to give you this nice view coming around the front of the brainstem. And what is the aim of doing this? What does this give us beyond a standard retrosigmoid approach? So what you're really trying to do is expand your surgical corridor. So if you have a particularly high lesions, like this one here is actually going higher up, you get really good working angles on either side of the fifth cranial nerve, as we'll see later in the video, that you can really work on either side of the trigeminal. You've got this nice view above the tentorium. You pick up the cranial nerves very early or really further forward around the cerebellum. And usually the vessels, you see it much later. That of course has its pros and cons. Same with seeing the cranial nerve early, that's got its pros and cons. And that's different to some of the endoscopic approaches that would be taken where you get to the cranial nerves very late. And of course it obviates the need for a Silvan fissure splitting, which can also be used for some of these higher lesions. So let's just talk about some of the other options again. I'm advocating, when you're coming around the front of the brainstem, that you use this sort of transpetrosal, but equally a retrosigmoid is very reasonable. Some people, as I was talking earlier with this unlocking, you could then drill and drill low down, but for me, I wouldn't go lower than the IM, but of course, there are surgeons who would. You could looking to do an OZ, splitting the fissure, even taking the anterior temporal veins and doing this pre-temporal approach, or a sort of approach through the cavernous sinus, which again will take you very nicely lower down. And of course, nowadays, there's the endoscopic approach, which is excellent for dealing with a lot of these tumors, particularly these softer tumors in front of the brainstem. And sometimes we would combine these approaches. Okay, so let's say you're going to do one of these cases. And as we've heard from a lot of speakers today, you have to really, really study the imaging. And for most skull-based pathology or extrinsic tumors, it's really about understanding the venous anatomy. The one vein, and of course you must try and protect all of the veins, but the one vein, of course, that is extremely unforgiving is the vein of Labe. Any sort of injury there is going to have severe consequences. So protecting the veins is key, especially the vein of Labe. It's useful to understand the transverse and sigmoid sinus and their dominance and how large they are, because you're going to have to be working against them to a degree in a lot of these pre-sigmoid or transpetrous approaches. Understanding how high the jugular bulb is important. You can lower the jugular bulb, but certainly you want to skeletonize the jugular bulb, because one disadvantage of this approach compared to the retrosigmoid is your view low in the CP angle is not as good. So you have to work to improve that view, and that really involves working around on the jugular bulb. And with all of these cases, you really want to understand where the draining veins are. You're going to protect all of the veins during the operation. The next step is to really understand the CT in these cases, and that's particularly you're looking at the pneumatization of the bone. So if you have a very pneumatized petrous bone, then you're going to find the drilling a lot easier, and of course you have to be careful, but it's usually a lot easier than if you have a much more solid bone. Occasionally you'd use this when there are intraosseous tumors invading through into the petrous, and then understanding the bone invasion when you're going to get onto bleeding. All of that is very important. The next important point, of course, is hearing, because as you'll all be fully aware, you can protect the hearing by going pre-sigmoid and going retrolabyrinthine. But if you go translabyrinthine, or the next extension transotic, then you're going to lose hearing the moment you enter into the labyrinth. So if you're looking to preserve hearing, and that is important, then we're really looking for a retrolabyrinthine approach. Then when it comes to counseling the patients, it's important to look and see what their preoperative clinical condition is. And I think this is where these tumors are different to a lot of other skull-based tumors. So with a lot of skull-based tumors, say if you take planar meningiomas or antrofossa tumors, although we say to patients it's really about stopping them getting worse, actually you expect them to get better. With careful technique, you decompress, you open the optic canal, take tumor out of optic canal in juxtacellular meningiomas, you expect the vision to get better. Same with some of these lateral petrous meningiomas, they have trigeminal neuralgia, things like that, you expect them to be better postoperatively. I think for some of these cases that is different. So I've shown a picture here of a petroclival where the pier is involved, cyst within the brainstem. I think here it's hard to make the patients better in these sort of cases. So I think here it's very important to make it clear to patients this is about stopping them getting worse. And I think the biggest predictor of how they're going to do in these cases, which are different to other skull-based cases, is what they're like before the operation, and your aim is to keep them as well after. And I think it is difficult to improve them in these cases and using these approaches. Then there's a question about what you're going to face during the operation. Now, I agree that particularly with vestibular schwannomas, as Emad was saying, that the larger the tumor is, preserving hearing things becomes much harder. For some of these tumors that are in front of the brains, these sort of tumors that we're talking about here, I think some of the other factors are much more important than the pure size. Yes, the larger tumors will take longer, but actually the other factors that I've listed here are much more important. And tumor consistency is probably one of the biggest factors. So with soft tumors, you can get excellent resections. You can really work the tumor away from the brainstem nicely. They're nice, usually nice planes, and get a very good resection. But with very tough tumors, and if there's a poor plane with the vessels, particularly the brainstem, cranial nerves, you're in for a very, very difficult day. The other thing, of course, is the vascularity. So this is an example of an extremely vascular tumor, schwannoma, that we did, and the vascularity really matters and does slow your progress. So for me, I think the plane, the consistency, the vascularity really matters. Size is important, but I think that's a much smaller factor for me. And these are important points when you're counseling the patients about what you're expecting to achieve during the operation. Okay, so we're going to do this. A lot of these times, although I'm not going to talk about it today, but a lot of times when we're using these pre-sigmoid or petrosectomy approaches, we would combine it with an anterior petrosectomy as well. And so you want a good size incision. It allows you to go, if you need, retrosigmoid as well, but usually, you get to the posterior petrosectomy, but you can also do an anterior petrosectomy with this sort of incision. I like to do it park bench. I find that the seating position is very good, but I like the sort of lateral park bench position. Now, these are the different sort of approaches that we're talking about here. You have the pure retrosigmoid approach, the real workhorse approach, excellent approach, very, very useful. And a lot of people would take on a tumor like this that way, and I think that's very reasonable. But today we're talking about approaches going through the petrous bone here. So either going retrolabyrinthine through the labyrinth, that's translabyrinthine. The transcochlear approach is not really used anymore. That's an approach where you would mobilize the facial nerve and you get a very high facial nerve palsy rate, and really is not an approach people use. There is a transotic approach, which if we have time, I'll talk about briefly, where you drill the cochlea, and in some cases we find that helpful. But this is what we're going to talk about today. We're talking about, you could go retrosigmoid, as you heard from the last talk, but this is now becoming pre-sigmoid through the petrous bone to take you much more further anterior and around the front of the brainstem. Okay. So this is what the operative view would look like. So we are now on the left-hand side of the patient. Okay, left-hand side, we've made an opening. We've got middle fossa dura exposed here, posterior fossa dura at the back here, sigmoid sinus, and we're going to start the drilling to take away in this pre-sigmoid area. Just for orientation, this is the external ear canal. And you'll do some of the bony drilling here. It'll take you down towards the cochlea. And the descending portion of the facial nerve, we've started to expose, coming towards the stylomastoid foramen. But the malleus there, indicating the first genu, superior semicircular canal with the second genu. And this is sort of anatomy you have to decide how much you're going to remove depending on your type of tumor. And I've just sort of drawn out in the same picture the various bits here. Okay, so these are your retrolabyrinthine air cells. These are your retrofacial air cells. Jugular bulb is going to be down there. And you have to decide if you want to preserve hearing, in which case you will drill retrolabyrinthine. If you want more exposure, you want to come further around the front of the brainstem. And we've drawn out the semicircular canals here, so you're going to drill translabyrinthine. Or if you want to get to the ascending portion of the carotid, which is useful in some of these tumors, I think that's a very difficult place to get to, either endoscopically or open. And then you would drill transotic. The one approach that we would never really use is transcochlear, where I said, you know, you transpose the facial nerve. We do not use that approach. Okay, so it's either retrolabyrinthine, translabyrinthine, and can add a transotic, and we normally add a anterior petrosectomy as well. The next step, as I said, is cutting the tentorium. So this is, again, left-hand side. This is posterior fossa dura. This is middle fossa dura. This is the sectioning of the tentorium. I like to use coagulation. I don't use clips or anything like that. This is the labyrinth. So we're showing a retrolabyrinthine approach. The superior petrosal sinus here. I'll just go back. The superior petrosal sinus there has been coagulated. Then I'm going to cut through it. We've drawn it a bit big here, but vein of Labe, which should really be further down here, but vein of Labe is shown in the picture and must be protected. So we would advise doing after the drilling, which I'll show in a minute in a video, we would advise doing a T-shaped incision, a horizontal incision in the middle fossa dura, an incision vertically or craniocordally in the posterior fossa dura. It's important to aim your incision towards the jugular bulb, because that is an area where your view can be restricted, and we can discuss it as time, some of the techniques for improving the view down there. You're then going to coagulate the superior petrosal sinus and then section the superior petrosal sinus and section the tentorium all the way to the tensorial incisura. You have to watch for the fourth nerve, but the fourth nerve is usually very anterior. And in this approach, unlike some of the other approaches coming from the middle fossa, it's actually very safe in terms of the fourth nerve. But you have to, obviously, whenever you're cutting the tentorium, you're always thinking the fourth nerve. You're always looking to protect the vein of Labe. And this is the kind of view you're trying to get inside. And the big difference here, well, there are a few big differences compared to the retrosigmoid when you do this pre-sigmoid approaches. And one of the big differences is you're much further forward, is the first thing to say. You're much further forward, you get onto the cranial nerves much more easily. The other thing I find incredibly helpful with this approach is you got the very wide corridors on either side of the fifth nerve, which you don't get unless you cut the tentorium. This is just an intraoperative picture showing the trigeminal nerve. And you can see this is the cranial, this is caudal. You just have this massive window here, which is very nice for working on tumors that are cranial to the fifth nerve. This shows an opening into Meckel's. So the corridors on either side of the fifth nerve are very nice. This is the fifth nerve, this is the seventh nerve, this is 9 and 10, and this is sort of the view you would get. The other thing you get is this angle going downwards to work downwards and clear tumor in front of the brainstem, and you're much further forward, as I said, compared to a retrosigmoid, which is very nice. Okay, so let's just, so we're going to watch the video again. This is actually a transaortic approach, so we're going to drill the labyrinth away, all of the retrolabyrinth area, and also drilling down here towards the cochlea. We'll skip the bit where we did an anterior petrosectomy as well. So we'll just start that. This is left-hand side. So this is the bony canal, the external bony canal drilling there. I do this in combination with my ENT colleagues who are very good. Here we've drilled into the cochlea, not a standard part of our approach normally. It's a basilar membrane of the cochlea. It's done with the ENT surgeons. But because it's transaortic, we're now drilling the labyrinth away. Semicircular canals are being drilled away to get that translabyrinth fine. I'll just pause it here nicely. It's a nice view. So just to reorientate you again, this is sigmoid sinus, middle fossa dura, posterior fossa pre-sigmoid dura. Jugular bulb will be there. We're starting to see it. You want to skeletonize that more. You'd want to drill medial to the jugular bulb. If you want, you can lower the jugular bulb. This is the 7th and 8th cranial nerves in the porus, and you have your superior and inferior gutters in a translabyrinthine approach. That's very important, getting all the way around. For acoustics here this is different, although we've done it anyway. And we're going to make our incisions along here in the middle fossa dura, here in the posterior fossa dura. We're also going to coagulate and then section the tentorium. Descending segment of facial nerve here. So we're just going to go forward now. I'm sorry, I'm just going to skip. These are the anterior petrosectomy bits, which I will skip. Okay. So we're now cutting posterior, sorry, that was middle. This is now posterior fossa dura. It's being sectioned. We've opened middle fossa dura. The view has changed. I'll just pause this again so people can understand what's going on. This is middle fossa cut. This is the posterior fossa incision. I've just got a bit of lyre step to protect over the sigmoid sinus. This is the superior petrosal sinus that we're coagulating. I don't like using dural clips. I think coagulating is better. Some people would even cut out part of the tentorium. I think that's very good. We've coagulated the sinus. We're now cutting the tentorium. Nice view inside. This is the trigeminal nerve, superior petrosal veins, distal SCA branch here. We're cutting the tentorium. We're looking to see where the fourth nerve is. The fourth nerve is usually much more anterior, and it's very safe. So we're sectioning the tentorium. I think in the interest of time, I'll just show the final sectioning of the tentorium. Unfortunately, the view gets a little bit less clear because I angle the scope to be really sure about the fourth nerve. So I've just done here. That's the final cut into the tentorium. Now I'm very clear that the fourth nerve is safe. It's usually much more anterior, the fourth nerve. And you just get this fantastic window. You can see this is the trigeminal nerve. You can see how you can work on either side. I really liked Emad's dissection. I like to use the bipolar and suction, but also peel on the arachnoid. But I use the bipolar and suction to work between the two. I think it's a bit more efficient. You can see a nice arachnoid layers, tumors coming off the brainstem very nicely. I'm going to skip forward here. Yeah, tumors coming off the brainstem very nicely here. See this fantastic view you have coming around the front of the brainstem. This is the fifth nerve. 7, 8 are here. I think in the interest of time, I will skip forward. We're just working on the tumor coming out nicely. Just to show you, this is the view towards the end. So this is, so I'll let it play. That's the lower cranial nerves there. 7, 8 is here. Tumor is nicely cleared off the brainstem. You can see the basilar artery. You can imagine using this approach with basilar artery and its branches if required. Coming here over the fifth nerve there. And you get a very nice view going nicely above the fifth. That's the fourth nerve going into the tentorium. But you'll see all the way up into the, these are the vessels around the midbrain. Okay. So I'll just move forward on that. So with even with very large tumors like this, you get very nice resections. Patients are importantly neurologically intact postoperatively. This is the patient here. She and her sisters ran a half marathon to raise money for our department afterwards. So she's in better shape than me after the operation. I think that's important. And you can combine it with other approaches as well. So this is, a tumor that a lot of people I think would have gone endoscopically, which is fine. I prefer to combine it with this sort of Transpetrous approach. You can see it's a complex but soft tumor, which makes it more straightforward, involving the cavernous sinus, towards the brainstem. So I combined that with this approach that I just described. You can, if you want, you could of course go on through the cavernous sinus, but I didn't do that. I combined an endoscopic approach with this approach, and you can see you get very nice resections using these approaches. Fortunately left a small amount of residual there, but otherwise a good resection, and this patient is intact and doing very well from their chordoma. I'll just briefly mention the transotic approach for people maybe a bit more advanced, but this is what the picture we saw earlier. This is the descending facial nerve. Obviously the view you get inside the brainstem. This is the ascending carotid. This is an area that's very hard to get to both endoscopically and open, but actually by drilling out to the transotic approach, you get in there quite nicely. You can remove tumors, particularly chordomas, all of that from there. Okay, well, thank you very much. Obviously, this is a team effort. I've listed lots of people here in our team, particularly Sam McKeith, who is who's my ENT surgeon who works with me on the lateral skull base side. I've got other neurosurgery and ENT colleagues, and Rahul Shah helped me a lot with the pictures and the editing as one of our residents. Thank you very much.
Thank you, Sanjeeva. It was extremely didactic, and you showed us which are the gaps, which are the indications, which are the limits, and how you manage with this approach. And we have several questions, and Serge is asking you what happens if intraoperatively suddenly you have a damage on the vein of Labe. What should be your next step?
Okay, well, unfortunately, at that point, things are a bit late, I think. So there's lots of tricks you can use to protect the vein of Labe, which may be the more useful. First, you have to identify it. I think it's Ernest Niemeyer who described this very nice technique. You can put a bit of Surgicel and Tisiel on it to keep it a bit stronger. I don't use retractors, as you probably saw there. So there's no issues with retraction and trying to pull on it. I think once it's damaged, what can you do? There's not a lot you can do. You can try and pack and try and preserve its integrity if you can, but I think a lot of the focus has to be really on protecting it, identifying where it is, trying to make it stronger. There are tricks you can use with Tisiel, Surgicel, things like that, to prevent that from happening. Extremely unforgiving vein, as we all know. Imad's putting his hand up. He might have a technique.
Yes. Look, usually in these cases, when I use the pre-sigmoid approach, including the modified Hakuba, I call it, because I extend it sometimes more forward. I'd like, if there is some borderline hydrocephalus, I'm operating on the left side specifically, I like to put an EVD because it makes the temporal lobe much relaxed, and then you have a control on your retraction. You are minimizing your retraction very much by doing this. So this is a small trick I have been doing for the last couple of years, and I found it is very helpful. And this is a temporary, you can always take it out.
Any other comments from the panelists?
One comment as well, I think Dr. Sanjeeva mentioned, which is very important by doing this approach. You have to take the bone and go all the way down almost to the jugular bud. Because if you don't mobilize the sigmoid adequately, then you are not getting benefit from this approach. So you have to go down to mobilize that dura posteriorly with the sigmoid sinus. And the other things I'll do, other than coagulation, I don't trust coagulation on that petrosal sinus, to tell you the truth. I like to ligate it. I do ligation, double ligation and cut in between. It's very, very safe and simple procedure. But I'm always concerned about the vein of that superior petrosal sinus. But it's a nice approach, as you said. Once you do it, you spend time, but then you have open door to the most of the skull base. From cranial nerve, even you see the tract of the optic down to 11. It's a fantastic approach, but it's time consuming and the drilling amount is much. And Hakuba has published taking the semicircular canal and skeletizing only the bone and leaving the membranous. But these people, from the 8 cases they done, they lost hearing in 4 of them. So you don't want to replace a case where you can maintain the hearing, because this case, like the one you showed, the big petroclival meningioma, perhaps she's still having hearing, isn't it? She is not vestibular schwannoma. And you
yes,
don't want,
correct. So in those ones, we look to go retrolabyrinthine. I agree. I think the moment you start drilling at the labyrinth, it's hard to protect hearing.
Yeah.
So we looked, if they have hearing, we look to go retrolab for it. And with the jugular bulb, just to come back to that, it's not just, you're quite right, we should expose it, but also you have to drill medial to it to really get the space.
And I want to ask Henry, because that case of chordoma, you mentioned the endoscope. I'm more inclined nowadays when I see chordoma, midline, purely midline, I will go for the transfemoral surgery or transoral surgery, whatever, with the endoscope. It's a fantastic because you are directly on the lesion and you take a good amount without all these conventional, I call it, we used to do all the complex approaches to far lateral and to go to these lesions. But the purely midline clival lesions, I think this is a primary indication for endoscopy. Do you agree to this, Henry?
Yeah, I agree.
What's your opinion?
I think this case was an ideal case for purely endoscopic because it was not far lateral. So I think with a 45-degree endoscope, and we have even a curved burr, diamond burr, where you can really go to these areas and you can drill the bone away, which is infiltrated, I think, for the medial ones. But I would just want to make a comment to the pre-sigmoid approach. In Germany, most people have abandoned to do it. In the case what you showed, I would try a retro-sig. Of course, the angle of view is not the same like a pre-sigmoid, but the risks are larger with the pre-sigmoid approach. And even Sami said in most of the cases he has abandoned this approach. And also Seifert, he switched completely to retro-sig for the petroclival meningiomas, at least for most of them. And if you have a blind corner, we use endoscopes like Imad has shown, and you can look in the frontal area of the brainstem, you can look to Meckel's cave and other areas.
No, I think retrosigmoid, and that is a work, most of these cases we would do retrosig, but I think for me, it shortens your working distance, you're much closer. For some of the more difficult tumors, I really like it, and I think it's very nice. But you're right, you can drill, you can do a reverse Kawase, you can cut the tentorium, there's lots you can do retrosigmoid that can give you that view without the drilling. I don't think the risks go up except for hearing. The drilling is not that complicated.
Sami reported some venous problems when he cuts a tent and he coagulates the superior petrosal sinus, and incidentally there was some problems with the vein of Labane, and this really may cause major problems.
And we haven't seen that, although we study the venous supply very carefully pre-op. But you're right, it theoretically could happen, definitely.
That's what is mentioned in Hakuba's and Ohata paper. That's why they studied the venous system, because even not touching the Labé vein, by itself, the petrosal vein can be a catastrophe if it's the major draining to the system.
Yeah.
And sometimes you never predict it unless you do a good MRV and you study it well, as you mentioned.
Yeah, I think it's very important because in microvascular decompression, we see so many variations. Sometimes you have 3-4 big veins and you think the whole cerebellum is draining via this petrosal vein complex. And sometimes it's just a minor one. It's very variable. And that's what you also mentioned. It's very important. We have to look for each case very carefully at the MR images. Yeah.
No, I agree fully. And we're very lucky. We've got very good neuroradiologists that really help us with that. So.
Yeah.
Well, I have something to say, Sanjeeva. Well, the pre-sigmoid approach, I think we have done it. And, you know, the drilling itself is 6 hours to 7 hours. If your ENT colleague is doing it, fantastic. But if you are doing it, you don't want to get on a tumor completely tired and drained. So the best way for me is an anterior petrosectomy. It is about 2 centimeter to 3 centimeter incision. And then you do an anterior petrosectomy, you devascularize the tumor, and you're cutting the superior petrosal sinus way anteriorly. This is much more safer than cutting it posteriorly. The only problem is you have to visualize the fourth, and then at the fourth, you have to go a little bit posteriorly. And if you do that, your access to these petroclival tumors is very easy. Otherwise, you'll be sitting and doing. I remember a live case in India where I went and did this with Vinod, and we ended up doing the tumor at 2 a.m., 3 a.m. in the morning. You know, it's a bit crazy. I mean, and it's too much effort for nothing. So if you start an anterior petrosectomy, it's much, much more easier. But I see that you have a good ENT colleague, so I guess it's all right.
Yeah, the only thing I mean, we were on a cadaveric course together where you demonstrated that very nicely, going very low with that. Yeah. I think that's difficult to do, actually, what you described, getting very low with an anterior petrosectomy, although you went very low there, or maybe to the jugular foramen, I think. But I think for most people that'd be hard to do. And yes, you're right, I've got a very good ENT colleague, so I'm having coffee while that's happening. So.
Dr. Sanjeeva, Dr. Hakuba has described the combination, pre and retrosig.
Yes.
And that's what we were doing. We're doing the pre-sigmoid, but we complemented with the retromastoid.
Yeah.
Retrosig approach. So it gives you access to a lower part of the posterior fossa.
I agree. And that is one weakness, seeing that very low bit with this pre-sigmoid approach. You are restricted by the jugular bulb.
But for the participant and for the attendee, they should go to the lab, learn all these approaches. Nothing comes from nothing. I mean, you have to learn something, and then you make the judgment how you will, when you need it, you know how to do it. And this is important. You learn the anatomy first, not live, but without the concern and the stress of vascular injuries or cranial nerve deficits. So using the lab and attend the masters while they are doing procedures, this is one of the recipe, like Halstead say, the best venue is the ward, the station. And for surgeon, the best venue is to go to the OR, watch these masters. We all did it. We all did it. I'm sure Professor Benish and myself, all of you were to one of these masters. We learn from them. We see what we can adapt and what we can get away from. And this is, I think, the message for the young people there. They have to attend this kind of surgery with the masters and go to the lab, do a lot of anatomical dissection.
Now, and although I have an ENT surgeon, I think it's really important you understand this anatomy, so you understand what view you can get, what they can do more for you. Same with the anterofossa endoscopy. I think we have to understand the anatomy as well as the ENT guys do. So you really understand where they can get you, what you can do with these approaches for complex skull-based lesions. I agree fully.
Pablo and Sanjeeva, you want to conclude this session, or you have still something you want to get the people to discuss something?
I don't know if you were checking the chat, but we had people from many countries, and the last 100 messages, they are all thanking you for your time and for being here, for your discussions. And I think we need to thank them for being there, because otherwise it's nonsense.
So we are going to conclude the sessions, and would like to thank the faculties that they were patient with me, with my correspondence, and they stayed long beyond the assigned time for today. And of course, the participants, they are the most important. We need their feedback, and I hope there will be some kind of evaluation from their side, how we are going in the future, because we have the plan, Professor Benish and myself and the team, to continue this as a dynamic course. But it seems this is the trend now, not only one-time events. with the COVID-19, and perhaps even in the future, it is less costly for the trainees, no traveling, and they are getting this, and we hope it will continue to be free as we planned it. And we will continue next month. We'll assign the day, we'll announce it, and there will be dynamic changing the lectures, modifying speakers, they can change the topics, but we need the feedback. Without the feedback, and you mentioned it, Pablo, we have a positive feedback, but from the 2,500 registrant, we'd like to have some kind of an informative statistic how we will go for the next plan.
So tomorrow, once we conclude, we will give them a website where they can fill up a
feedback
app, and we will be informed, and then they will be able to get the certificate also.
I'd like to ask Vladimir, is he with us?
Yeah,
Vladimir, you want to say something, please?
No, thanks to all. Thanks to the faculty, thanks to the attendees. And Pablo, thanks to you. That was great.
And Sanjeeva.
I think that we shall meet tomorrow at the same number. What was the number, Pablo?
Well, it was difficult to measure because we were here 500. That was the limit for Zoom. We are trying to increase it by tomorrow, but there were like 400 in YouTube. I don't know how many with Neurosurgical TV, so maybe 1,500, something like that.
Great.
Ipe, I want to say hi for the nice lady behind you. She is the master in table tennis.
Alona.
You should change the spots, you know. I go to the background.
Hi, Alona. Nice to see you.
Nice to see you.
And
we would be happy to be on your farm, Ipe.
Yeah, anytime.
All of you, I am missing all of you guys, everybody.
We don't have to do an online course in your farm. We will come physically. All right. So thank you. Thanks, everybody. Thanks, John Bennett as well. I don't see him here. We should give him appreciation as well.
He's recording it, I believe.
John is there. John is around. John is transmitting through Neurosurgical TV.
Is he? Okay.
Okay. Bye, Pablo.
See you tomorrow.
Yeah. Thank you.
See you tomorrow. Bye-bye.
You guys.
Nice seeing you. Bye-bye.
Bye.
Fantastic. Thank you.
Viva.
Pablo.